coming home someday. Lucky I'm in love with my best friend. Lucky to have been where we had been. Lucky to be coming home again. My heart this song and let me sing forevermore. Tell me I'm the lucky one you worship and adore. Your heart makes when you're fast asleep. In dreams you lose your heartaches. Whatever you wish for you keep. Have faith in your dreams and someday your rainbow will come smiling through. No matter how your heart is grieving, if you keep on believing, the dream that you wish will come true.
Can come true. It can happen to you if you're young at heart. For it's hard, you will find, to be never of mine if you're young at heart. You can go to extremes with impossible schemes. You can laugh when your dreams fall apart at the seams. Your life gets more exciting when each passing day. And love is either in your heart or on its way.
Your heart made your fast asleep. You lose your heart. Whatever wish for you have faith in your dreams, and someday your rainbow will come smiling through. No matter how your heart is grieving, if you keep on believing, the dream that you wish will come true.
Let's fall in love, why shouldn't we fall in love? Our hearts are made of fate, let's take a change. Why be afraid of fate? Let's close our eyes and make our own paradise. Little we know it, still we can try to make a go of it. We might having meant for each other. To be or not to be, let our hearts discover. Let's fall in love. Why shouldn't we fall in love? Now is the time for it while we are young. Let's fall in love.
Good morning everyone. Pleasure to have you around. We should be starting shortly. I guess the rains may have kept a couple of us from getting here. But please note that there's a walk-in tea break. That you can please have a cup of coffee, a cup of tea, light patience. Those around you. You don't know who might be sitting around you. The person may be a VIP. We should be starting in the next 5 to 10 minutes. Thank you and speak to you shortly.
Let's fall in love. Why shouldn't we fall in love? Our hearts are made of fate. Let's take a change. Why be afraid of fate? Oh, no. Let's close our eyes and make our own paradise. Little we know of it, still we can try to make a go of it. Not having meant for each other. To be or not to be, let our hearts discover. Let's fall in love. Why shouldn't we fall in love? Now is the time for it while we are young. Let's fall in love. Let's fall in love. Oh. When I fall in love, it will be forever, or I'll never fall in love. Oh yeah, in a restless world, like they say, love is ended before it began, and too many want to breathe. Moonlight kisses seems to cool in the warmth of the sun. Yeah, yeah, just sing it out loud.
When I give my heart,
I feel it now, yeah.
it will be gone in me.
Oh,
I'll never give my heart.
I will never give my heart.
And the moment I can
when I fall in love, right now it will be forever. Alright, never fall in love. Yeah, sing it now.
In a restless life, listen, that there's something before it's begun, and tonight, like it seems to grow in the warmth of the sun. When I give
my heart,
it will be complete.
complete because you love me.
I'll never give
Never give
my heart. And the moment I can feel that,
you feel that way. When I fall in love,
when I fall in love with
and now the end is near, and so I face the final curtain. My friend, I'll say it clear, I'll state my case of which I'm certain. I'll live a life that's full. I've privileged, and every highway and more, much more than this. I did it my way. Regrets that of you, but then again to view the dimension. I did what I had to do and saw it through without exception. I planned each other cars, each carousel along the byway, and more, much more boundless. I did it my way. Yes, there were times I'm sure you knew when I beat up more than I could chew. But through it all, and there was doubt, I ate it up and spit it out. I faced it all, and I stood out. Yes, did when I get off more than I could chew, but through it all, when I was dead, I ate it up and spit it out. I faced it all and I stood all and did it my way. For what is a man? What has he got if not himself? That he has not to say the things he truly feels, and not the words of one who kneels. The record shows I took the blows and did it my way. The record shows I took the blows and did it my yes, my own way.
Nothing you can make can't be made. No one you can say that can't be saved. Nothing you can do, but you can learn how to be you in time. It's easy. All you need is love. All you need is love. All you need is love. Love is all you There's nothing you can make that can't be made. No one you can say that can't be saved. Nothing you can do, but you can learn how to be you in time. It's easy. There's nothing you can know that isn't known. Nothing you can see that isn't shown. There's nowhere you can be that isn't where you're meant to be. It's easy. All you need is love. All you need is love. All you need is love. Love is all you need. All you need is love.
Close your eyes, make a wish, and blow out the candlelight. For tonight is just your night. We're gonna celebrate all through the night. Pour the wine, light the fire. Girl, your wish is my command. I submit to your demands. I will do anything. Girl, you need only yes. I'll make love to you like you want me to, and I'll hold you tight, baby, all through the night. I'll make love to you when you want me to, and I will not let go till you tell me to. Girl, relax, let's go slow. I ain't got nowhere to go. I'm just gonna concentrate on you. Girl, are you ready? It's gonna be a long night. Throw your clothes on the floor. I'm gonna take my clothes off too. I made plans to be with you. Girl, whatever you ask me, you know I could do. I'll make love to you like you want me to, and I'll hold you tight, baby, all through the night. I'll make love to you when you want me to, and I will not let go till you tell me to. Baby, tonight is your night, and I will do you right. Just make a wish on your night. Anything that you ask, I will give you the love of your life, your life, your life. I'll make love to you like you want me to, and I'll hold you tight, baby, all through the night. I'll make love to you when you want me to, and I will not let go till you tell me to. I'll make love to you like you want me to, and I'll hold you tight, baby, all through the night. I'll make love to you when you want me to, and I will not let go till you tell me to. I don't drink coffee, I take tea.
All right, good morning, everyone. Thank you, media. Please bring it down. Good morning, ladies and gentlemen. Thank you, distinguished guests and participants, and to our virtual audience. Thank you so much for streaming. They've been with us since 10 a.m., so we're moving in now. All right, thank you. May we get settled, please? All right, so welcome to the much anticipated launch of the 2023 State of State Report, brought to you by BudgIT. My name is Nancy Odumegu, Communications Officer at BudgIT, and I'm being joined by one of BudgIT's finest, quintessential man according to our Global Director, in the person of Viola Kwaga, our Senior Research and Policy Analyst here at BudgIT Foundation. All right, it's a pleasure to moderate this very important occasion, and like I said earlier, it's the State of State Report launch for 2023, and the theme of which we're going to steer the entire conversation is Subnational Healthcare Delivery for Improved Economic Development.
Good morning, everyone. Thank you so much for that warm introduction, Nancy. The State of States, well, we've been doing this for nearly a decade now. It's an insight or a perspective into how states are run. Every one of us is a citizen of one state in Nigeria. And how well are states performing in terms of their fiscals? How well are they saving money? How well are they raising revenue? How well are they spending? How much debt do they have? And how has that impacted on their governance? Being the brainchild of BudgIT's foremost and first head of research and global director, the State of States is a deep dive into the fiscals, the financials, the domestic research, 36 Nigerian states, and it's meant to give a bird's eye view, if you will, on how well states are being run. So there's going to be a lot of numbers, there's going to be a lot of analysis, and my colleague, the head of research, Inyobong Usen, will be taking us through a presentation a little while from now, and he will be the one really boring you. I won't bore you so much. So once again, you are welcome to the 2023 State of States. We are delighted to have you, and it's a pleasure to have you around.
Thank you very much, Viola. Before we move on, we're being joined by distinguished dignitaries in our midst, and please allow us to recognize them and give honor to whom honor is due. Without wasting much of our time, we have here the Executive Governor of Kwara State and the Chairman Nigeria's Governors Forum in the person of Governor Abdulrazak Abdulrahman. A round of applause for him. Thank you very much. So wherever you are, we have a special seat just in front. Thank you. Please keep clapping until he comes to this. Yes, thank you, until he takes his seat. Thank you very much. We also have our keynote speaker for today. He will be coming on shortly. Okay. All right. Okay, so just in a minute. Okay. A round of applause for Governor Abdulrazak Abdulrahman, a man that wears many hats, the Executive Governor of Kwara State, as well as the Chairman Nigeria's Governors Forum. Thank you very much for joining us this morning, sir.
And he was here early, actually 5 minutes before time.
Yes, a very punctual person. Thank you very much. We are honored. All right, we'll have also our keynote speaker in the person of Dr. Olumide Okunola. A round of applause for him. Dr. Olumide Okunola. Yes, a round of applause. Yes, he's a World Bank specialist. Is he here with us? Yes, he's here. Please, a round of applause. Dr. Olumide is a World Bank health specialist, and he will be giving us a keynote speech not far from now. Yes, we're just waiting for him to have a seat. Okay. Thank you so much. Thank you so much, sir. All right, moving on.
Thank you, Nancy. So we are here to discuss the State of States, and every year we have a specific sub-theme. There was a time we looked at improved revenue mobilization, domestic resource mobilization. There was a year we looked at subnational reforms for a new era.
Yeah.
This year we are looking specifically at health.
Yeah.
And the star members of this health theme are the executive secretaries of our focus states, as we like to call them. I will be calling them up to the front seats so they can get comfortable. Let me start with our very own Dr. Abdulrahman Shuaibu. He's the Executive Secretary, Primary Healthcare Development Agency, Gombe State. Let's give him a round of applause as he comes up. So we'll also have Dr. Babagana K. Machina. He's the Executive Secretary, Primary Healthcare Development Agency, Yobe State. And thirdly, we have Dr. Bello Jamo Yusuf, the Executive Secretary, Kaduna State Primary Healthcare Board.
Thank you for coming.
We also have the Commissioner for the Ministry of Primary Healthcare, Niger State. He just stepped out, but I'm sure he should be back shortly. Thank you.
Thank you very much, Viola. We also have the Commissioner for Finance, who's representing the Rivers State Governor, Sim Fubare, represented by the Commissioner for Finance, Isaac Kamalu. A round of applause for him, please. Honorable Commissioner, thank you so much for coming. We have the Commissioner of Budget and Planning for Edo State here, represented by the Permanent Secretary, Edo State Ministry of Budget, Isiarehen Efe. Please pardon me yes, thank you so much for joining us, sir. All right, without much ado, we'll be rising for the national anthem. Shall we rise as we kick off? Thank you very much for that. May we have our seat? As we set the stage for today's discussion, it is with immense pleasure to invite a leader who has been at the forefront of budget vision, no other person than our country director, Gabriel Okelwo, as he takes us with the opening remark and we move from there. A round of applause for Gabriel Okelwo. Please, let's keep clapping until he gets here for his opening remark. Thank you so much.
Make it manners, someone say, then he's the hero of the...
Thank you, Viola and Nancy. Good morning, everyone. Your Excellency, the Executive Governor of Kwara State and the Chairman, Nigerian Governors Forum, Governor Abdulrazak Abdulrahman, you are welcome, sir. Your Excellency, the representative of the Governor of Edo State, the representative of the Governor of Rivers State, we welcome you to this meeting. You are welcome. The Executive Director and CEO of the National Primary Healthcare Development Agency, Dr. Faiza Shuaib, ably represented here by Dr. A.B. Garba, the Director of Planning, Research and Statistics. You are welcome, sir. The Honorable Commissioner for Primary Health, Niger State. He came in earlier on. I think he's not on seat right now. We welcome him in absentia. The Executive Secretary, Gombe State Primary Healthcare Development Agency. Thank you very much, sir. The Executive Secretary, Yobe State Primary Healthcare Management Board, Dr. Babagana Machina. We thank you for being here. The Executive Secretary, Kano State Primary Healthcare Management Board, is not here. I hope he will join us in the course of this meeting. The Executive Secretary, Kaduna State Primary Healthcare Management Board, Dr. Jamo, you are welcome, sir. The other government dignitaries that might be in this room that we may not have recognized, we welcome every one of you to this occasion. We are hoping also that the Bill and Melinda Gates Foundation, who have been our firm supporter since the inception of the State of State Research will also be joining us in the course of this meeting. And right away, I see the DG, Nigerian Governors Forum. You are also welcome, sir. Our keynote speaker for today, Dr. Olumide Okunola, Senior Health Specialist at the World Bank. We welcome you very warmly, sir. The moderator of today's panel, the civil society leaders that we have in this room, development partners, we welcome you. I see Chris Okeke from FCDO. I see some other leaders in this room. Every one of you, we welcome you. The Board of Trustees and Executive Management of BudgIT Foundation, I welcome every one of us. Members of the press, ladies and gentlemen, good morning everyone once again. It is a great pleasure for me to welcome us to this 7th edition of the State of State Report launch. If we count State of State, this will be the 9th edition. But the first 2 editions we are done in 2015 and 2016 under our bushel, without so much noise about it. But in terms of launching the report publicly to the public, this is the 7th edition, and we are glad that every one of us that is in this room this morning, you are able to join us for this occasion. BudgIT is 12 years old, and we are counting. And over the last 12 years, BudgIT have used creative technology to simplify public information, stimulating a community of active citizens, and enabling their rights to demand accountability, institutional reforms, efficient service delivery, and equitable society. For the State of State Research, we run this research every year with the aim of providing accurate and up-to-date information on the fiscal decision of all the 36 states in the Federal Republic of Nigeria. And we do this because most of the time attention is largely on the federal government. So State of State gives us opportunity to take our attention for a minute away from the federal government and look into the books and the activities of the 36 states in Nigeria. And I know that over the years, people have been clamoring for us to add FCT to that list. And we hope that in the near future, we are also going to be able to look into the books of FCT. The report is also a comparative assessment of the fiscal performance and position of each of the states in the Federation. The State of States looks at how states can finance their budget with revenues generated internally and their level of dependence on the federally allocated revenue. It also considered how states is prioritizing investments in human capital development and the sustainability of borrowings of the states. Over the last 7 years, the State of State has become a reference document for most state governments in Nigeria, as well as public finance management experts, foreign investors, development partners, and the academia. Since inception, we have always added a sub-theme research to the State of State annually. So beyond just analyzing the figures and the books of the states, we use the opportunity of the State of State research every year to research into certain dimensions, certain potentials of the state. And in the past, we have looked at the export potentials of each state. We have looked at several other topics. And this year, we narrowed down to subnational healthcare delivery for economic development. Because we believe that a healthy people makes a healthy state, makes a healthy nation. This year, our focus is on subnational health for improved economic development, and we have added the assessment of the current level of healthcare delivery in each state to this report. And I believe later on, when my colleague will come to give us a bit of, idea into what this report entails, we are going to be saying. And then every one of us will be able to go with a copy of the report. At the same time, when we launch the report here, it's also going to be publicly available on our website for everyone to be able to download the soft copy. Our aim for this particular report is to spark conversation that calls attention to the need for subnational government to prioritize investment in primary healthcare service delivery. In addition to the anticipated improved response from government, we have also kickstarted a project on strengthening community engagement and accountability for primary health care, which we are implementing in Gombe, Kano, Kaduna, Yobe, and Niger states. And it is my privilege this morning that all the executive secretaries that are leading this agency in all of these 5 states are here present with us here at this meeting. Our special thanks to the Bill and Melinda Gates Foundation for their unflinching support for this research work over the last 7 years. I am also particularly, and very particularly, I had noted this in my address, but the governor just confirmed it again, because I'm particularly grateful to the governor of, the executive governor of Kwara State, His Excellency Governor Abdulrazak Abdulrahman. And I believe that every one of us that were in when he arrived, he broke another kind of record today, because for the first time, we had a governor just walking, without so much detail, no protocol. And then we even have to be asking ourselves, is that the governor? Is that not the governor? That is a great one. Please help me put a round of applause for the executive governor. I hope that we can ride on your presence here, sir, to request for an opportunity to present this report in a closed-door meeting to the other governors of the Federal Republic of Nigeria. I wish every one of us a very productive time here today, and I hope that this report and the conversation that will follow will contribute to the development of a great nation, our great nation, Nigeria. Please, aside from the keynote address, and I believe after the keynote address, there will be opportunity for questions, there will be opportunity for contributions. We have a panel session where we are going to be looking at subnational health delivery, particularly with attention on the 5 states, but we know that the focus of this conversation is the 36 states in Nigeria. We are going to be using the 5 states that are here represented to have an idea to share with us what is happening in terms of investment of government in primary healthcare delivery. And then at that point, the floor is going to be open in the room for us to make this meeting participatory. We would like to hear from you. It is not a monologue. We would like to speak from here, and we also like to hear from you, your questions, your contribution. I wish us a very engaging meeting here today, and at the end of today, I hope that you will be convinced that you have spent your time wisely in this event today. Thank you once again for being here. God bless you.
Thank you, Mr. Gabriel. Great goodwill message as always. Thank you, everyone, for your rapt attention. We are going to shift gears a little bit, but before then, I'd like to kindly ask that we at the back just move forward a little bit. There are a few empty seats in the tables in front of you, because we're expecting a lot more people to be coming in a few minutes. Once again, to those online, thank you for sticking around. And as Mr. Gabriel said, it's not going to be a monologue. At a couple of times during today's event, we would field questions from the audience as well as those online. So we would get an opportunity to provide feedback and ask questions as the case may be. Right, so we are going into the first major part of today's event. We're going to hear from the senior health specialist at the World Bank, Dr. Olumide Okunola. He's been wonderful so far, great conversations he and I have been having on the phone. And I'm really looking forward to his perspective, sort of like a broad-based perspective on some of the work that the bank is doing in health, and some of his own concerns and also ideas around healthcare. So it brings me great pleasure to invite Dr. Olumide Okunola, the Senior Health Specialist of the World Bank, up to the podium to deliver his keynote on subnational health delivery for improved economic development. Let's give him a round of applause, please, as he comes up. Please, let's keep on clapping. Once he's done, we would have a brief question and answer session on his keynote. Would probably pass the mic around for a couple of comments. Thank you, Doctor.
Excuse me, I'm sharing my screen, but this is not it. Huh? Yeah, so I'm already sharing online. No, this is not it.
One minute, please. Yes, sir. Yes, sir.
So while we wait for Dr. Olumide to set up, or rather for the tech team to set up, we'll be taking some goodwill messages. Our first goodwill presentation would come from the Commissioner for Finance, Rivers State, representing the Executive Governor of Rivers State, Mr. Isaac Kamalu. He'll be coming up to give us a few comments, and we'll then hear from the representative of the Edo State Governor, the Permanent Secretary, Mr. Efe. So let's give Mr. Isaac a round of applause as he comes up for his goodwill message. I just saw walking in now the Commissioner for Primary Health Care, Ministry of Primary Health Care, Niger State. He's joining his colleagues in front. You're welcome, Doctor.
Your Excellency, the Executive Governor of Kwara State and Chairman of the Nigerian Governors Forum, Your Excellency, the representative of the Governor of Edo State, distinguished Chief Executives of Primary Health Care boards of the respective states that are here, the Board of Directors and the management of BudgIT Foundation, very eminent and distinguished leaders who are here, members of the press, distinguished ladies and gentlemen. His Excellency Sir Siminalayi Fubara, GSSROX, Governor of Rivers State, has very warmly asked me to pass his kind wishes to the board and management of BudgIT Foundation. The Rivers State government have been a very good ally of the BudgIT Foundation. And over the years, we have participated in your programs. We recall that we were 2-time awardees in 3 consecutive roles of the state as the best state in terms of physical execution of projects. And so it's not surprising that your work is getting across the length and breadth of the entire country. The presence of the chairman of the Nigerian Governors Forum in this very event is testimony to the fact that you are amply recognized for the very wonderful work you're doing. His Excellency had thought that he would personally be here because of the special role you play, and particularly because of the theme for this year, which has to do with primary health care. As the Nigerian Governors Forum acknowledged awardee as leader for the South-South for primary health care, is a subject that is very dear to our state. But owing to commitments, he is unable to be here, and so I have been asked to stand in for him. But we want to thank you, just like we have said once again, for this extraordinary work you're doing to our country. There is no doubt that by your efforts and assignments, you have enabled the state and Nigerian citizens to be active citizens of this great country. And on behalf of His Excellency, we want to thank you for the invitation extended to us and wish you very fruitful deliberations. Thank you, sir.
Thank you very much for those very brief remarks from the representative of the Executive Governor of Rivers State. That was Mr. Isaac Kamalu. Very quickly, we would have the Permanent Secretary, Ministry of Budget and Planning, Edo State, representing the Governor of Edo State, Mr. Iseriahen Efe. Please let's give him a round of applause as he makes his way to the front. Let's keep on clapping. After him, we would have the representative of the DG of the National Primary Healthcare Development Agency, representing Dr. Faisal Shuaib. We have Dr. A.B. Garba. Thank you very much, sir.
The Executive Governor of Kwara State, permit me to leverage the already well-established protocol and bring greetings from His Excellency, the Executive Governor of Edo State, Mr. Godwin Noregase Obaseki, who is unavoidably absent for this event, but I am standing in for him. He has asked me to thank BudgIT for all the support they've given to Edo State, particularly in the area of budget review. I know for so many years, they've supported us in doing the citizen version of our budget. And anytime we call on them, they are willing and able to give us the required support. There was a particular year, around 2020 or so, they supported us in producing the citizen budget, and we never acknowledged when we did the publication, and it did not go well with them. We apologized, they saw with us, and they kept on supporting us. Thank you once again. There was a certain incident that happened between BudgIT and our state. There was a certain publication they did. It did not go well with us. We have to write to them that this report is unacceptable to us. But the way they came back to explain the step-by-step they took in arriving at that position, that we needed to have apologized to them. We want to thank you once again. And I want to thank you for the theme of today's event. Health is wealth has been alluded by so many people. And issue of primary health care is very dear to the heart of our executive governor. He's making effort to ensure that there is a model primary health care center in the 174 ward in Edo State. And is frantically working on it. I don't want to bore you with so many things. I want to thank you for what you have done for us in the past. I want to thank you for what you are currently doing for us. And above all, I want to thank you for the support that you are still going to give to us. Thank you.
Thank you very much for those candid remarks, Mr. Efe. I do recall that incident. And it's interesting because governance is not easy. Dr. Abdul Fattah Abdurrahman of Kwara State would probably have stories for days about how challenging it is. But when you can have frank, candid conversations with civil society organizations, advocates, and rights people in the right space, it does bring a flavor to governance and it does improve it, much more broadly. Thank you very much for your comments, sir. It's a pleasure for us to have you around. Very quickly, we would have the representative of the DG of the National Primary Healthcare Development Agency, Dr. A.B. Garba. Would like to be calling him up for his own goodwill remarks. Let's give him a round of applause. After him, we would have another goodwill remark from a very special person who just came in not too long ago, our global director. Please let's give a round of applause as Dr. Garba makes his way to the front of the podium, representing the DG, Dr. Faisal Shuaib of the National Primary Healthcare Development Agency. Thank you very much, sir.
Thank you. Maybe I should kindly request that I stand on the well-established protocol, Your Excellency. I hope I get that permission. I also continue by expressing the apology of my Chief Executive, Dr. Faisal Shuaib, who actually wanted to come, but as I'm talking to you, he's also having a meeting with the minister. Myself, I was also going somewhere when I was discharged to come here. And that is NPCDA. We are always working. So this is the message he asked me to deliver at this event. It is my pleasure to be here amongst distinguished participants at the launching of the 2023 State of States report with a theme aptly targeted primary health care delivery, a pathway to economic development. If recent memories serve us well, the COVID-19 pandemic lockdowns and the catastrophic global economic impacts could not have depicted more clearly the old adage that health is wealth. A fundamental challenge for our health sector, amidst others, is the persistent underfunding of primary health care, which is the foundation of the nation's healthcare service delivery. Despite the knowledge and the global evidence that PHC remains the veritable reform in our recent stage of economic development to achieve universal health coverage and the sustainable development goals, our national health interventions continue to be skewed towards higher levels of care in the typical inverted pyramidal fashion. This fundamental and persistent challenge facing the implementation of primary health care bears the most negative impact at the state level, with frequent fluctuations in both political and fiscal commitment to health, as it delivers quality primary health care services with the resultant reversal in our health statistics and the adherent human capital economic benefits. States must take full fiscal ownership of PHC and to consider the additional resources from the federal government as catalytic funding to drive results. The federal government, through the National Primary Health Development Agency, based on its mandate, has continued to make significant inroads in collaboration with our partners and stakeholders in our support to state to improve coordination, financing, and accountability for health outcome. The NPCDA has continued to provide the necessary leadership to the primary health care level, particularly in the areas of improving access to basic reproductive, maternal, newborn, and child health care services through our joint emergency actions at the national and state emergency maternal and child health intervention centers. which are systematically addressing our poor indices by taking concrete steps to improve the availability of skilled attendants at BUD and the quality of care. The most recent fallout of these efforts is the recent launching of the CRIPS program, which is the Community-Based Research, Innovative Training, and Services Program, which is a collaborative effort with the states and teaching hospitals across the Federation to improve the availability of skilled BUD attendants in the frontline primary health facilities and improving the quality of care for the entire spectrum of productive maternal and child health. This initiative is set to commence this quarter with 12 states. To promote demand, community health education, and utilization of facility-based services, over 20,000 community health influencers, promoters, and services program chiefs have been engaged, trained, and deployed across 290 local governments across creating effective linkages between health facilities and our communities. On the immunization front, which is our largest area of intervention, the federal government of Nigeria and the Federal Ministry of Health, working through the National Primary Care Development Agency, have made landmark strides, working with its partners, stakeholders, traditional leaders, and the private sector. In 2020, we collectively successfully eradicated the wild polio virus. We continue to work to prevent the resurgence of COVID-19, having contributed significantly to its control during the pandemic by minimizing morbidity and mortality through vaccination of Nigerians and other PHC interventions. To date, over 80% of targeted Nigerian population have been reached with at least one dose of COVID-19 vaccine. And we are also achieving up to 70% with full vaccination. Furthermore, working with our partners and the states, which are the most critical stakeholders to success, we have improved routine immunization coverage by over 24% in the last 3 years. And we are poised to significantly increase coverage by the end of this year, next year, and once and for all begin to hold vaccine preventable diseases in its track. Likewise, we are assiduously working and engaging the states on our way to reduce zero-dose children, i.e. those who have never received any vaccine and serve as a reservoir for outbreaks, even as we are battling with success the recent diphtheria outbreak across states in Nigeria, across states. With the commitment demonstrated by the executive governors of the worst hit states, diphtheria hit states like Kano, Kaduna, Katsina, Borno, Bauchi, and Yobe, which I have just visited, I am confident that the outbreak will quickly come under control, despite and in collaboration with our partners, that the state will take the prescribed actions to curb zero-dose children and show up with routine immunization. These interventions and many more are part of the costed federal government's 10-year strategy for primary health care revamping based on 4-point agenda, namely improving access to quality quality primary care services, PSC revitalization by addressing infrastructure, human resources, commodity, and logistic gaps, health promotion and demand stimulation, program delivery based on the world minimum package. This strategy, which has the full buy-in of our partners and the states, was launched at the 2022 PHC Summit and is the basis of prioritization of our health intervention, including responses to outbreak. The implementation of this strategy is our key to placing Nigeria firmly on the path to the achieving of Millennium Development Goals and the universal health coverage. However, to succeed in delivery on this strategy, states must fully commit to making new investments and sustaining fiscal support for primary health care across all states, particularly those with the most dismal indices. This is a critical point where the budget report to be launched today is most critical. A detailed fiscal space assessment, such as been done for the state, in the state by state report is indicative of the ability of the state to invest in health and will significantly provide necessary evidence for targeted advocacy for health and innovative approaches to finance, particularly at the subnational level. The federal government on its part has continued to demonstrate its commitment to the financing of primary health care through the passage of the National Health Act and more recently the National Health Insurance Authority Act. These two acts have and will be transformational in the implementation of primary health care across Nigeria. The National Health Act, through the Basic Health Care Provision Fund, the NPHCD Gateway is already making successful intergovernmental transfers to over 8,000 Basic Health Care Provision Fund benefiting facilities to meet daily operational costs and systematically improve evidence delivery, service delivery. On the NHIA gateway, as estimated, 1.2 million additional vulnerable Nigerians have been provided with health insurance cover under the Basic Health Care Provision Fund to access a basic package of health service delivery as a model for the deployment of the Vulnerable Group Fund under the NHIA Act as soon as it becomes operational. Without new additional investment by all stakeholders, the private sector, our donor communities, and most importantly, states, we are unlikely to meet the required coverage and targets to make Nigerians healthier, build our human capital, and yield the massive potential benefits from our teeming population. States especially must invest in the revitalization of primary health care facility to meet the prescribed national standard, invest to stem the drain on the health workers force, and meet necessary obligations and commitments, including payments of required counterpart funding for the Basic Health Care Provision Fund, and investing in necessary equity funds to expand insurance coverage and save our citizens from the current catastrophic high cost of out-of-pocket expenses on health. This investment will build redundant in our PHC services, promote social trust, create uptake in utilization, and serve as a platform for a more effective and response national health security architecture in the event of outbreaks and epidemics. Let me at this point congratulate BudgIT for today's successful event and bring this vital financial information to fore in your excellent report. Let me at this point wholeheartedly congratulate Sokoto and Jigawa states, which were reported to have fulfilled at their level the Abuja declaration of 50% budgetary allocation to health. A deeper glance at the report also clearly demonstrated the important correlation between fiscal space and health outcome, with many of the least performing performers financially posting the poorest health indicators. The launch must, however, not be viewed as conclusion of a job well done and the product delivered, but the start of a catalytic change process. We look forward to partnering with BudgIT and similar non-governmental organizations and community-based organizations as we are already doing it, seeking newer innovative modeling approaches to translating this report into advocacy tool by exploiting the impact on health fiscal space and jointly evolving strategies to effectively engage the private sector, the donor community, and other critical arms of government such as the financial sector to raise the necessary investment and funding primary health care so desperately needs. We must consider options that provide better performance-based models to incentive states when assessing federal government funding and advocate for fundamental amendments to our constitution which places health on the reclusive list. I think it's exclusive, supposed to be exclusive, yes, it's an error. I am sure that during the course of our engagement here today, more special solutions will be prepared with passions fueled to make that difference, particularly for our state counterpart. I thank the budget team for the opportunity and wish us all the best of deliberations as we craft the way forward to this prepared, healthier, well-financed future Nigerians. Thank you, and God bless you. And you know, as a messenger, I'm bound to make mistakes. Therefore, I apologize for the wrong messages that I might have, submitted to you as a human being. So take the correct messages from my chief executive, but then forgive me for the errors that I might completed. Thank you.
Thank you very much, sir. To err is human, to forgive is divine. Thank you very much for that very lengthy but very comprehensive and concise speech. I'm sure you're wondering, why did we give him so much time? Well, this is a health-focused deliberation. So this is part of the framing for subsequent discussions and comments and remarks that we'll be having today. There's a lot I'd like to comment on what he has said, but chiefly among, which I think is important, is the need for joint planning between the federal government and the states and coordination, going forward, hence why we have these esteemed gentlemen from the various states in the north. So very quickly, we would have comments, goodwill message from our very own global director. Following him, we would hear from His Excellency Abdurrahman Abdulrazak, the Executive Governor of Kwara State and the Chairman of the Nigerian Governors Forum. Then we'd hear from one more person, and then we would go straight to the keynote. So with a round of applause, let's welcome Mr. Oluseun Onigbinde, BudgIT's Global Director, for his goodwill messages. Thank you, sir.
Okay, thank you very much. When you are asked to give a goodwill message, you know that there's a connotation there that your time is almost up in the organization, because they're not allowing me to give any long speech. They just want me to say a few things. But I want to thank the staff and the management of BudgIT for putting this together. Thank you so much. One of the fewest times they deliberately don't allow me see the reports, even though I went behind them to get it one way or the other. But I want to thank you for the work that's been done. I want to thank everyone who's been here. The Vice President, let me recognize that we have the representative of the Vice President here, a good friend of mine, Mr. Tokwe Fashua, who's a special advisor to the President, to the President on economic affairs. A round of applause for him, please. Thank you so much, the Governor of Kwara State and the Chairman of the Nigeria Governors Forum. Yesterday, Gabriel was asking me that, is this our first, second, seventh, ninth edition? I told him this is our ninth edition. We had two reports, 2015 and 2016. Then we started hosting events in 2017. And I'm happy that our partner, our trusted partner in this venture, the Gates Foundation, they've been with us from 2017 when we started this whole event. And the mission for us was simple. The context was in 2015, states were not even publishing budgets. Public budget was a difficult thing to see. One of our staff, who works with the presidency now, was arrested in Delta State because he asked for the public budget. So we knew that the opportunity to engage was difficult at that point. So we said, let's even start with what was available. And what was available was FAC reports was available, IGR reports were available, and also we could also see Accountant General and Auditor General's report, and we quietly started building out a ranking. And gradually it has become something that is great for banks. It's been used by debt rating agencies. It's been used by multilateral institutions. We fine-tuned the methodology over and over with the World Bank and IMF to make sure that we get to where we are right now. And we have seen a whole lot of reception and pushback even from states about wherever their ranking is or wherever they find themselves. I just feel excited that what started with a small vision with the team, myself, Atiku, Samuel, and the rest of the team then has blossomed to something that's great. And not just blossomed, people like Gabriel Okeowo, Abel Akeni, Ojuigo, Inyo Bong, and the entire research team, has kept faith in this whole idea, and we have taken it so forward. I'm really, really excited. I don't want to take too much time. I'm not the keynote speaker, and this is not the 10th anniversary. So when we have the 10th anniversary, we can go into a long list of issues and also of history. But thank you so much for being here today and for gracing this occasion. This is like our major flagship event of the year, the State of States, and also speaks to our interest in subnational governance in the country. Will permit me to introduce our next speaker, who is the governor of Kwara State and also the chair of the Nigeria Governors Forum. Governor Abdul Razak. Please, a round of applause for him, please. So.
Representative of governors, top government functionaries, the BudgIT Foundation, distinguished ladies and gentlemen, and of course, gentlemen of the press. On behalf of the Nigerian Governors Forum, I sincerely congratulate BudgIT on this important occasion. I also commend all the different partners who collaborated in making this a reality. This event is significant to national debate on healthcare delivery in speaking to the increasing relevance of civil groups and stakeholders in shaping conventional policies, allocation of resources, and decision making. Once again, I congratulate BudgIT and groups like it for the impact they have made in constructively redirecting attention to issues of accountability, transparency, and service delivery. This has helped guide government officers and institutions to see things differently. That's the major and is the best major part and beauty of democracy. This kind of engagement is a pointer to how far we have come as a country, regardless of the huge challenges we have ahead of us. I believe this report will contain specific recommendations and point to different issues that subnationals must pay attention to for better service delivery. But beyond funding gaps, sometimes foggy policy outlooks, and the question of accountability on part of government institutions, I believe another issue that should engage our attention is how attitude of different stakeholders, especially individuals at subnational level, can make huge difference in our journey to greatness in this country. I assure BudgIT and our partners that the NGF will thoroughly study the report, which will then be cascaded to different layers of government for better outcomes. Thank you very much.
Thank you, Mr. Governor. Excellent speech. Let's give him a round of applause. And BudgIT would also like to crave your indulgence to allow us disseminate this report perhaps to the NGF in session, if possible. Thank you very much, Your Excellency. Very quickly, we will have next on the podium Dr. Tokpe Fasua, the Special Advisor to the President on Economic Matters in the Office of the Vice President, come up. Let's give him a round of applause. Dr. Tokpe Fasua is a writer whom I admire so much. Thank you, sir.
Thank you very much. Thank you very much. I'm actually here representing the Vice President. At short notice, though, there's no prepared speech. Start with the protocols. His Excellency Governor Kwara State and Chairman of the Governors Forum. Government officials here present. Keynote speaker, my friend and brother, Dr. Olumide, founder of BudgIT, Sheung, I think he's disappeared somewhere. The BudgIT team, gentlemen and ladies of the press, even though we always hear only gentlemen of the press, but I believe there are ladies amongst them. Ladies and gentlemen, well, very quickly to congratulate and commend BudgIT for its yeoman's job over the years, and they've been setting new standards in responsibility and accountability for Nigeria's budgeting and public finances they started, and this is well acknowledged. The truth being that oftentimes we maybe are just naturally wired to expect that development will come very quickly. But it takes efforts like what BudgIT has been doing for that gradual shift to begin to happen. And sometimes we may be able to look back and see that a lot has changed in our society. BudgIT has been one of the very catalytic institutions, I must say. And of course, today, the focus is on healthcare. And whereas I'm an advisor on the economy, but we also know that saying that health is wealth, meaning that health is economy. Without good health in society, there's little we can do in terms of growing GDP and all of that. If GDP is meant to be the total summation of goods and services that's produced in a country in a given year. So it's a very commendable one that, that BudgIT has focused on health today in this State of States 2023 edition. However, now it's great that BudgIT has since drilled down to states. However, I'm also wondering, maybe there will come a time very soon when we would also begin to mainstream state of local government, given the fact that many of them have been abandoned, rural areas. It's just when you go to some of those places, some of the situation is pathetic in many instances. And however, I personally believe that the next spike of growth in our economy actually resides in those rural areas. So it'll be good at some point to be able to say, okay, you know what, let's try and focus our excellencies, governors, on some of those local areas, and let's see how they're doing side by side. Also, we talk a lot about healthcare allocation in budget. I don't know from where I'm standing today what exactly the United Nations said it should be, maybe 15% or 20% or thereabout. But what about efficiency in spending? There are many abandoned PHCs across Nigeria, especially in rural areas. That's primary healthcare centers, totally abandoned. Of course, we're going through the Japa phenomenon, meaning we don't have enough healthcare providers and professionals actually servicing those areas. Even in the urban areas, we have a big problem. There are rapidly shifting demographics, some of them influenced by global events, which we must study and document as things stand. What's happening to our society? We're not very good at documenting such things, much less conveying them and relating them to the public for every Nigerian to know exactly what the issues are. Perhaps Dr. Lumide's paper today would actually look at some of those issues. Lastly, I want to say that we, as a government, and on behalf of the Vice President, we will take on board the data and positions put forward and presented in your report, State of States 2023, and put forward and use the report integrally with the other plans of government. And we want to assure you we're working assiduously to ensure that we have a better Nigeria. Thank you very much for the opportunity.
Thank you very much for those goodwill remarks. It's always a pleasure to know that every level of government is involved. And like he said, we hope for a day when we can involve the local governments as well. A lot of governance happens at that level. Unfortunately, not much is said or discussed about it. Very quickly, I'd like to recognize the presence of the representative of the Enugu State Governor. We have Mr. Chukwuka Ugu, the Permanent Secretary, Enugu State Liaison Office, here with us. Can we just give him a round of applause? There he is. Thank you very much. He's representing the Executive Governor of Enugu State, Mr. Peter Mba. Thank you very much, sir. Very quickly, before I call on the next person to give a goodwill message, would like to crave the indulgence of His Excellency Governor Abdul Razak to hang on, because we would like him to be the chief launcher of this year's State of States. We would ensure that we stick to time, sir. Yes, so very quickly we would have the country director of the Bill and Melinda Gates Foundation, represented by Ms. Katia Shillenwato. The BMGF, as it were, keeps the lights on for the state of states. And from its inception to now, they have been funding. And it's important that we sound this, because without them, a lot of this analysis would not happen. And a lot of the innovations, the insights, the discussions, the quality of engagement that we now know today about the states, is chiefly due to the Bill and Melinda Gates Foundation. So it would be remiss of us not to have them say one or two words. So, Ms. Katia Shillenwato, you have the floor. Let's give her a round of applause.
And I promise not to take too much time, but just standing on all existing protocols, Your Excellency, it's great to see you. I just want to take the opportunity to thank the BudgIT team. I know they say it's the funding that makes it possible, but we really believe it's the people that make it possible, which is why we've invested in human capital development in Nigeria over the last 10 years, and our cross-cutting portfolio in health, in education, in agriculture, in financial inclusion. And I think more importantly, all the work that we do around supporting organizations to develop data and insights. So it was really great to hear the representative of the Vice President say that, the evidence and the data from the report will be actioned by the government of Nigeria. And I just wanted to highlight that, working with organizations like BudgIT, really enable a lot of the accountability, transparency, and processes that societies need to thrive. And I hope that this is work that will continue enjoying the support of the government, but also of other partners. And I think when you think about the sustainability of this work, it's important to bring in other partners so that it's really a joint and co-owned effort of all of Nigeria. And so with that, I come with greetings from our country director, who couldn't be here today unavoidably due to a conflict in his schedule. But just to thank the BudgIT team for being an incredible partner all of these years. BudgIT is a learning organization just like we are, so our values align. The more they learn, we also learn. And it's just been an incredible, incredible partnership over the last, 6, 7 years to see where this conversation now is, in terms of really focusing on subnational engagement. I also just want to recognize our work with the Nigeria Governors Forum, which I think is also critical to this subnational engagement, as well as the Nigeria Economic Summit Group, which, as you know, next week the summit is holding. So I'm hoping to see most of you there. Thank you so much, and looking forward to fruitful discussions today. Thank you.
Thank you, ma'am, for that, again, very candid set of remarks. So yes, now we'll go, again, shifting gears to the keynote speech. We had him here some moments ago. I guess the tech team has settled on the slides. So we'll be having the keynote speech, keynote presentation by Dr. Olumide Okunola. He's the health specialist with the World Bank, and he'll be coming up for his keynote presentation. Please, let's give him a round of applause.
Good morning, Your Excellency Governor, Special Advisor to the President, distinguished guests, colleagues. This is quite an interesting presentation because I've had the opportunity for it to be peer-reviewed by a state governor. So just an hour before this event started, I had the privilege of spending some time with Governor Abdulrazak. He hadn't seen my presentation. He didn't know what I was going to speak. He didn't even know that I was going to talk. But we spent 30 minutes discussing. And in fact, several of my assumptions, he tore them apart. Some of them he confirmed. So I think one thing I came away with from my little interaction and conversation with Governor Abdulrazak is that there are a couple of things that needs to be done going forward. to BudgIT and colleagues here. One, we are not engaging with the political policymakers enough. The kind of solutions that came out from those discussions, there are things that is not being considered. All the parliamentarians in the parliament on health committees in the National Assembly, they are 2 doors away. And we need to have a whole lot more of this kind of discussions. So please, everyone, a round of applause for His Excellency the Governor for being here. And in fact, just in the course of that conversation, he mentioned that he might even be inviting the Minister of Health, so that there can be some engagements, So as I said, I've learned a lot just speaking to you. So, but I then just very quickly share some thoughts. I make this, or I give this talk, basically from the perspective of universal health coverage. When you speak on healthcare from a position of universal health coverage, then it means that a few things become a bit more important. There's something about the word universality. Universal health coverage, universal basic education. Once you begin to use such words, they're not buzzwords. It means that you have made a commitment to include the poor and vulnerable in whatever service you want to deliver. So I hear every time, UHC, universal basic education. Once you use those words, then you are taking everybody along and you don't want to leave anyone behind. So I'm getting somewhere. This is not my presentation. I'm just laying the foundation. And to understand universality, it's also important to understand that where we are today, if you disaggregate our population, the poor and vulnerable are increasing by the day. Impacted by the COVID, high inflation, you now have global tensions. It means there might be bombs being dropped somewhere. It means that the poor and vulnerable here, life becomes more difficult. That's what it means. So these numbers, at this point, the last count, about 90 million or so, it simply means that this will increase. If it increases, it means that one person somewhere would need to make a choice between, do I treat my child for malaria, very anemic, or I buy a loaf of bread for the house? Those are the kind of decisions that are being made in households, especially here, that we tag poor and vulnerable. We're lucky we're here at the swanky Hilton Hotel in Abuja, far from where life is tough and hard and tough decisions are being made. It gets even worse, but don't let me get ahead of myself. Because someone who is hypertensive, his drugs per month, 2 months ago, cost him about 20,000 naira. Those same set of hypertensives will be in the region of 100,000 naira now. In fact, if that person is in this category, the person cannot even afford those antihypertensives. But slow down, we'll get there. Another thing then, so I said universal health coverage. You have poor, vulnerable households increasing. Old slide, I tried to get a recent slide, but I didn't have to do this quickly. But this is also a country that has the bulk of its economy in the informal sector. Note my word. Informal sector doesn't mean that everybody in the informal sector is poor. But because they're in the informal sector, we don't even know who they are. The person might be making revenues of 1 million, selling recharge cards, but he's not in the formal sector. We don't know him. He doesn't pay tax. As I said, this first set of slides is just for us to begin to situate where we are. So let's collectively understand a population that has an increasing number of poor vulnerable households. A population that has mostly informal, and also when you have poor vulnerable households, you want to even guarantee them basic healthcare services. Meaning that what is their problem at this point in time? Malaria, diarrhea, upper respiratory tract infections. Meaning then that the services that they require, these people, the services they require today, sits where? It's not in the University College Hospital, it's not in Luth, it is in the public PHC. That smallest unit of service delivery. If you can guarantee them, these people here, those basic services, that will be a lot of progress. So, I hope to answer 3 questions. Where we are today, what's our scorecard? The second will be what led to that scorecard, whether we passed or failed. Then what will be my own thoughts? Of course, most of the perspectives there are mine, so not of the institution I represent. So I'm not sure whether these things are clear, but the data that you all have, maternal mortality rate, that is the number of women per 100,000 live births. Official data says 800, some will say 500. The latest one, if you Google it, says 1,045. You know what that means? Pretty much, even whether, the unfortunate thing is whether you're rich or poor, in Nigeria today, the possibility of going into a health facility to deliver a child and come back alive is really, the chances are very dim that you may survive. It is one of the highest in the world. But it's not just maternal mortality that is high. Neonatal mortality rate, infant mortality rate, under 5 mortality, the basic health indicators for Nigeria ranks as some of the worst globally. But I would rather interpret those numbers in my next statement, which, so again, total fertility rate, the average number of kids a woman would have in her reproductive lifespan, 5.3. In certain regions of the country, it's as high as 7. Some, it's even higher if you go to the individual level. Let me just very quickly go on to what that means. Some of this is, let me just interpret it for you. So, there are some countries in the world, they are said to have made progress with their demographics. In fact, if you look at the countries called the East Asian Tigers, South Korea, Indonesia now, and all those countries there, what is it that they've done in terms of their demography? 30% of their economic growth, and I'm coming out there so that, you know, Dr. Tokwe Fashua, who works with the president, can also understand that economic growth is not necessarily happening in the financial sector, but also what we discuss here in health matters to economic growth. So what did those countries do? Because of improvements in public health primary care services, 2 things happened. 1, child mortality reduced. If you look at our own, child mortality is high. When a woman gives birth to 1 child and is sure that this child will survive, that woman will not have 10 kids and will not have that kind of high fertility rates that I'm showing for Nigeria. So, child mortality dropped And because of the decisions the women were making, fertility also dropped. And because of that, but a caveat, just doing those alone will not give you the economic growth, but you also have to empower that population with the skills that they require. So those countries improved health services, also gave them the necessary skills. Bottom line, at the end of the day, those countries became quite wealthy. Here, we are very delayed with our demographic transition because of those high numbers, high fertility, high under 5, and other kinds of indicators. So bottom line, without much ado, we are clearly not doing well. Not doing well means that the kind of economic potential that we should be deriving from improved health outcomes, we're not getting it. So why are we where we are? This is my presentation, perhaps my most important slide. If you unpack this is why we have those kind of poor health outcomes. You can apply this in education, apply it anywhere. In fact, the governor, as I said, without even seeing these slides, our 30 minutes conversation pretty much discussed this. And I would just very quickly just go through somewhat each one of these. But fiscal federalism structure, perhaps something that we have not interrogated as much. Nigeria is a federation. It is one of the largest federations in the world. India is a federation, and other, Mexico, Brazil, they are federations. But there is a reason why countries use that kind of political administrative system. One order of government cannot ask the other order of government to disappear. Fundamental of federalism. But there are also other things too. Within a federal structure, the national government could say, you know what? I can put some sweeteners on the table so that you can improve one or two things. All sort of things within the federation. We will try and see how that has played out in the health sector. Beyond federation as a system, what are the institutions underpinning that federation? So, this democracy, what does it really mean for us? Both affect how we also make money. Do we have a diversified economy, or we're just a mono economy? How much money at the end of the day are we able to make? How much are we prioritizing to health? And how has that led to the kind of result card that I shared? Let's just take them one after the other. I've not spent too much time on this. It's not my area of specialty, but just to know that Nigeria is a big country, low middle income country, but our revenue raising potential is one of the lowest in the world. For me, this is the first thing and almost a contradiction to my mantra on universal health coverage, which was where I started from. This is important for universal health coverage because without public financing, this kind of revenues that's being raised, your journey towards universal health coverage becomes very tough. Because it is public financing that will help guarantee those poor and vulnerable households so that they don't make those kind of tough choices I said earlier on. Yet, if public financing is so important and our revenue raising ability and capability is so low, then how do we achieve universal health coverage? Just to say that at about 7% of GDP, it's a far cry that on the average, countries will require about 15%. So we got a long way to go. But first point to know. So first, we're not raising enough public financing to be able to improve our health outcomes. But that's on the aggregate. Since you have asked me to talk about states, at the level of the states, it's even worse. The internally generated revenue potential of the states is almost non-existent. Thank you for some of our reform-minded governors now who are trying to extract as much as they can. But because of the dependence on the FAC allocation every month, a lot of states have abandoned IGR. But thankfully, we're going back there now. But that is also another reason why public financing, we are not raising enough public financing. Okay, so whatever we have raised, you may not understand this, but this is the way all of those revenues now flow to various actions and activities. All of those arrows, let's simplify it here. Two things that you note, because we'll come back to some of them towards the end of the presentation. Bottom line, every month, people sit down in Abuja and share FAC every month, which is what is published and some of the data you use. This is what belongs to federal government, that's what belongs to states. You don't need to be a statistician, you don't need to be an ophthalmologist, but I mentioned service delivery happens even at levels below the state, at the local government level, which is what those poor and vulnerable households require. But just looking at this chart, you will see that the federal government retains most of the revenue. Who are the people that the federal government is providing services for? So there are some fundamental questions to be asked, even before we start blaming state governments. But of course, they're not things we can deal with because these are even things in the realm of the Constitution. But here, you can begin to see some of the structural issues. Excellency, you mentioned the word reset. In fact, this is some of those areas where that word reset might become applicable. But there are also some solutions here, and we'll come back there. So, beyond the revenues that we are raising, and I've also mentioned that the poor and vulnerable, we know what they want and we know where they get their services. But most of the monies that are meant to go to the PHCs don't get there. Two reasons. Whatever they get, 95% of it is spent on salaries. And then they get nothing else. Meaning then that the public PHC that's meant to deliver all of those essential services do not receive no operational expenses to deliver any meaningful care. Unless these things change, let's just be clear, there will be no improvements. The second is, okay, if there's even anything left, there's a lot of tension between the governors and the local government entities. And that's played out in the media in the past couple of weeks. So these are some of the constraints that were, again, if you look at the FAC allocations that we showed earlier on, if you are not raising enough money, where there's a constraint, where money is tight, the allocation you even get becomes tougher. So low IGR, overall low revenue mobilization, you're not even getting enough share. All of this comes together to present a really major fiscal constraint. At the end of the day, what do we see? What does it all come to? This is an old slide, but I was a bit more comfortable using this slide. It comes to $15, $16 per capita. That is the amount of, if we divide it across all Nigerians, that means the typical Nigerian is receiving $16 per capita spend of public financing on healthcare. In other countries, you're talking about $1,000, $3,000 per capita. This number, if we have more time, we can even find out that it's much lower. Because this number is budgeted, not released. So I'm a bit more comfortable with this. But the latest figures are even saying about $12 per capita. And that's if 100% release happens. The state governments are here. So at the end of the day, the average Nigerian gets about $5 to $6 per capita of healthcare, which is unlikely to buy much. Okay, maybe when there's a crisis, at least where your house is burning, or where your house, you know that there's going to be a problem, you go and get, you prioritize fire mitigating equipment and all of that. So, during COVID, you got to put money into healthcare. Several states did so. But even at that, it was still modest. So this is budgetary allocation in the middle of COVID. And just to mention that the monies were beyond prioritization, beyond allocation. Even when you appropriate, does not mean that it gets to the front line where it's going to be used. And there are all sorts of reforms that are put in place, including the use of strategic purchasing entities, so that let's even purchase care a bit more efficiently. So you set up health insurance schemes. How has that performed? So right now, what we do in the country is we are still doing passive purchasing through the ministries of health, and the strategic purchaser, that is the health insurance entities, either national or state, they receive little money to even get the efficient use of the little you have. So difference. There's passive purchasing of healthcare, there's strategic purchasing of healthcare. The difference in strategic is I know who the person is, I know what I'm buying, and I know what I'm paying for. So you are able to get, real value for the money you are spending. Okay, we set them up, but the amount of money going through them is so low that it doesn't really make any difference. So the inefficiencies question looms really large. And lastly, we're not spending enough. The little we do, though the little we're spending, we spend on tertiary healthcare facilities, where only a few people get to. Most state governments, by the way, have university teaching hospitals. And we have not necessarily addressed what the majority of the population in those states require. So, let's go to my last bit of this presentation. First is, okay, and I have elaborated a great deal on, money is tight, states don't get enough money, but you also have the federal saying, you know what, let me incentivize states for good behavior. So in education, you have 2% coming from the consolidated revenue of the federal government to say, okay, let me give you this so that you can at least improve primary education. I leave what has happened on UBEC to you. But the same thing also in healthcare. 1% BHCPF. Said, let's try and incentivize good behavior. There are a couple of things that has happened with that 1%. In several states, it's probably the only game in town, which wasn't really the intention, because it's actually helped to leverage additional financing from our governors. But one thing that needs to happen there is we need to improve the use of these funds. We need to be better accountable for how we use it, and we need to be able to demonstrate results if we're going to ask for additional funds. But there's an opportunity there in terms of what we need to do. Another opportunity, perhaps, if I were a betting man. So we already have federal government giving states 1% through the BHCPF. Can we ask that we take, I would say, well, we take an additional 1%, not from federal government now, but from the pot that everybody shares. So this is the money that is shared every month in Abuja, but can we take 1% from there? That's an extraordinary amount of money. Don't let's kid ourselves. But His Excellency, I tested this with the governor this morning, and he said, well, have you even accounted for how you have spent this before you start talking about this? Valid point. But surely there's an opportunity here. It's going to take an extraordinary consensus to take something from here. Huge political battle, but it's possible. But it's just for us to just throw some ideas out there. A third will be, okay, my money is tight. I don't have enough money, but I need to use this public financing judiciously. Okay, so let's then prioritize to the most needy, those who deserve it the most, and those who are the most vulnerable. And that's why I would, you got the National Social Registry. And one of the things the governor mentioned earlier on today is, look, I don't trust this registry because there are political connotations to it and all of that. But not that, in fact, data needs to drive this kind of resource allocation. So it could be the National Social Registry or not, but if you are able to say, look, I have identified the people who are most vulnerable. So the little we have, let's prioritize those ones. Maybe other people can pay, but that will be a major step forward. So I think using the state social registers presents a very useful opportunity going forward. In fact, you can disaggregate that data that you have. So if this is a typical state of poor people, just one state, and you can say, look, this is divided up into deciles. That, look, the poorest deciles, maybe decile 1 and 2, let's fund them through BHCPF. Deciles 3 and 4, let's fund them through the equity fund of the state. And you begin to say, look, in fact, in the state, I could say, you know what? I can cover 100% of people identified as poor and vulnerable in my state. It would be such kind of rational allocation. Not so rational because, of course, there are all sorts of political economy issues around here. But at least let's begin to have such a conversation going forward. Bringing all of this together then means, can we begin to allocate money based on output? I have 1 billion. The cost of package is 1,000. If I divide 1 billion or 1 million by 1,000, I know the number of beneficiaries that you can cater for. That might be, rather than right now, we are assuming that we are transferring money, and that money is somehow delivering health care. We may need to take a step back and look at some kind of performance-based budget allocation or output allocation where we are able to determine exactly what that money and who those people are. There's also other things around the use of this kind of model, because then the private sector can say, well, I like the cost, it's low, but it gives you an opportunity to at least know my revenue. And then you are able to mobilize in private sector to deliver services. Last point will be, I'm talking about not enough money and a low tax to GDP base. Countries are exploring things like pro-health taxes. The amount of taxes on things like alcohol, tobacco, sugar-sweetened beverages is one of the lowest in the world. And I'm bringing this out because what you gain at the roundabout, you lose at the corner. You don't tax now, you will have a population that's going to end up with huge prevalence of non-communicable diseases. So you that you don't have money, you will then begin to have things around hypertension, diabetes, and cancers. Tax high. Now, it's fine. You will make money, even if you don't make much, but you know that you've served as a deterrent for increasing the prevalence of these non-communicable diseases. So, just in summary, I think if we're able to focus on our population, make decisions, it shouldn't really be a tough decision in terms of, do we want to cover the entire population? But we know we don't have enough money, so can we cover at least those who require it the most, the poor and vulnerable? Can we begin to look at opportunities that's able to address these fiscal pressures? E.g., I gave the example of pro-health taxes and how, even states at that level can also begin to allocate some more money to cover this population. And I just end with, it might be useful, as some federations in India, in Mexico, in Argentina have done, and MC, I think, in addition to, because we have the NGF fully present here. It's not only the chairman is here, the executive secretary, the DJ of the NGF is here. What I have learned from COVID is that the NGF might not be formally recognized in the Constitution. Its twin sister in the Constitution is the National Economic Council, chaired by the Vice President. But there is a huge opportunity within the NGF in terms of having documents like this to create that peer pressure, to better understand how we can use compacts. The Gates Foundation have done this across a number of states. But we need to unpack it to say, what does it mean, so that we can begin to hold each other accountable. The kind of numbers that I shared early on, where somebody will say maternal mortality is 1,000, another person will say it's 500. Either way, the two are the worst in the world. It's completely unacceptable. And I believe, if just using the example of maternal mortality, we have a compact with state governments to say, just using the example of maternal mortality, I will pay for all maternal deliveries in my state and interrogate if any woman dies. By the way, President Kagame is doing that in Rwanda. No woman dies in Rwanda that is not investigated at the level of the presidency. That in itself wakes everybody up. And it's those kind of accountability arrangements, where you have the CSOs, where you have institutions like the NGF, where you have NEC. This might even be a lot more important than the monies that I've spent a fair deal of time talking about. Thank you very much.
Thank you so much, Dr. Okunola, for that incisive, comprehensive, broad presentation. I have a lot of questions, but I won't take any of mine. Very quickly, we would like to hear from the audience. Questions, comments. I'm afraid we have to keep it down to 3, not more than 3, because we are still going to hear from the head of research, Inyobong Usen, and his presentation on the state of states proper. Then we go to the launch so we can ensure that Governor Abdulrazak would be able to leave when he wants to. So a mic should be going around, and okay, my colleague Nancy would share the mic. So questions and comments for Dr. Okunola's presentation. Please let's keep them brief and straight to the point. If you have a question or comment, you can raise your hand so she can walk towards you.
Good morning, Doc. Thank you for your presentation. My name is Rachel Abuja. You just said we should add more money, yes, to the healthcare system. But I'll be wondering, or I'll say, when we are giving back money, we are returning money in the health sector, and you're asking us to add more money, is that going to be visible when we don't finish the one that we're being given? That's one. And the sugar tax, I was expecting that you're going to elaborate on it for the governor to see reasons why we should take it from 10% to 20%. Thank you very much.
So we'll just take all the questions at once, then he'll answer.
All right. Thank you, everyone. My name is Fidelis Obani, and I work with the Center for the Study of the Economies of Africa. Thank you, keynote speaker, for that insightful presentation. And I also want to talk about what the last person just spoke about SSB. We are talking about how we can increase tax on products like tobacco and sugar-sweetened beverages. This is a very good idea, sir. Currently, in my own organization, we are carrying out a kind of simulation study on how how we can generate more revenue from taxing SSB products and also tobacco products. So currently, according to World Bank report, I think the recommendation is 70 ad valorem tax on tobacco products. But currently, Nigeria is only charging 30%, which is way far below the recommendation. I think we can look at this area to generate more revenue and also discourage consumption of this kind of products in order to improve our health care in our country. Thank you.
Okay, Wilson Ikwebe is my name, Head of Advocacy, Partnership and Influencing, SOS Nigeria. My question is this. I think there is something that is very systemic and that is very structural that revolves around every aspect of the economy. From all indications, it affects very strategic aspects higher or more, like health and education and all that, and that is corruption. Is there a formula for addressing corruption, most especially in the health sector? Thank you.
Thank you very much, everyone. Apologies to those online. I'm sure they also had some questions. So very quickly, we would have Dr. Okunola address the questions, and then we would have Inyobong Usen step up to the podium for his presentation on the state of states proper. Dr. Okunola, you have the floor.
Thank you very much. Just to start with the question on corruption, yes, corruption is endemic, but in the health sector, I think I shared some sort of solution where you task an entity to do the purchasing for you. So that way, you are able to identify who the beneficiary is. We know how much the package is. We know who is going to deliver the services. So the concept of strategic purchasing pretty much helps to deliver, to address, it will not, there's still fraud in insurance systems, but at least you are able to follow the money, you're able to follow the patient amongst other things, unlike the current approach now, where we assume that through passive purchasing we'll be able to get healthcare. But that's just one part of it. Well, closely related to that is the question of absorptive capacity by Rachel. Well, I'm not even sure whether that happens pretty much at the state level. It's mostly national level, where billions and billions of monies are returned every year to the treasury, despite the fact that we're saying that not enough money is allocated to the health sector. There are a couple of things there. One, you also have constraints within what we call the public financial management systems. So there are new procurement rules. You cannot begin a procurement process unless you have all of the monies available or part of it available before you launch the procurement process. And then government is also working based on fiscal constraints. You get that money towards the end of the year and you want to do a 20 billion procurement. Sometimes it's just best for you to return it, but that's not also to say if you have the necessary leadership capabilities that where people are able to use planning methodology and forecasting methodologies, you are able to avoid these kind of things. I mean, the monies that are being returned can buy up, maternal health care, free maternal health care, and reduce maternal mortality almost to zero in 1 year. So there's a mix of things there, but I think the ministry also has constraints within extant laws, and but there's also a need to help empower leaders across our civil service to be able to use new tools to forecast and budget. In terms of sugar-sweetened beverages, the first issue has to do with the broader tax reform. What's the capability of the FRS? How automated is it? I mean, those are things I can't speak to, but certainly you need to start from there. Second is you also want to begin to look at what type of taxing arrangement. You mentioned ad valorem, sure, complex compared to specific taxes, where, it's everybody knows this is what the tax is. At best, okay, you do a combination of ad valorem and specific taxes. But the bottom line is, in this regard, we know that the level of taxation on those products are incredibly low. And there's an opportunity for government to expand the fiscal space by raising it. And I will put in my personal heart into the ring to say, earmark it for the sector. So that, yes, I mean, even though some will argue it's inefficient, but earmark it as an additional revenue for the sector so that you can ease things up. Yes, the Finance Act of 2021 introduced taxes on the sugar-sweetened beverages for the first time, but that was just too low, and you probably want to go as high as the 20% recommended by the WHO. However, it has been hard and difficult actualizing that because of the pushback from industry. And in countries where these same taxes have been introduced, it's actually led more to innovation in that industry, creating different other kind of products. And people didn't lose jobs, but here somewhat they've been able to stop government from doing the needful. But overall, regardless of several of the comments that we have made, the level of public financing for health is so low at 0.5% of public financing for the level of the economic size of Nigeria is completely unacceptable. And no matter the amount of efficiencies you put into that system, it is really too low to deliver the kind of health outcomes we want. Thank you so much.
Thank you. Let's give him a warm round of applause for his responses to the questions. I think the responses were almost as comprehensive as the presentation itself. Thank you once again, Dr. Kwonla. Very quickly, we would go to the presentation by BudgIT. We'll be having Inobong Usen come up to the stage. Thank you so much for your attention so far. Please give a round of applause to yourselves as well for your attention, and we are getting to the meat of the discussion. After Inobong, we would have one more submission, and then we would have the very fine gentleman you see seated in front, a commissioner and several executive secretaries, discuss in a panel moderated by Dr. Kemi Solagbaoye on primary health care at the level of the state. So the insights would be much more finely grained and nuanced. Very quickly, Inobong Usen, you have the floor. Thank you.
Yeah, thanks, Viola, and good afternoon, everyone. Thanks for making our time to join us here. I'd like to stand on existing protocol for time and just move straight into the presentation so that we would have enough time for the panel discussion. The keynote speaker, laid a very beautiful background for the conversation. And I know with all the data that was presented, it may seem as though it's all gloomy. But that's not to say that in recent times, we've not had, very minimal improvements. The truth is, in a number of states, some improvements have happened, though in piecemeal, attempts, but all the same, they have happened. But there's still, much room for improvement. For a lot of persons in the room, you might wonder, what's the direct correlation between the healthcare we're discussing today and all the numbers you see around budgets, around taxes, and all of that? But the Preston curve would show you that there's actually a very strong correlation between health outcomes and economic growth. If you look at Nigeria as a case study, you would see that, over the last couple of years, or almost a decade, our GDP per capita has remained stagnant. And if you want to look at our health outcomes as well, you would see that it follows almost the same trajectory. And data available shows that for countries that have better health outcomes, they definitely have, better economies, as the case may be. And the reverse is the case, when you have worse health outcomes. And for the state of states, year in, year out, we try to review the methodology to see, how best we can assess, comparatively, the fiscal health, fiscal viability of the 36 states. The FCT is not inclusive because for now, we do not have that level of transparency with regards to whether it's fiscal data or, other development-related data to be able to make them part of the conversation. And so for the methodology, all of the numbers you'll be seeing later on, this just shows what you're seeing on your screen is a sort of brief description of what the methodology is about. We have about 5 indexes. The first index, which we've given a weight of 25%, tries to see how states can meet their operating expenses with what they're able to generate internally. And for operating expenses, we're looking at the personnel cost, overhead cost, and the interest on loans. For the index A1, we see, the efforts that states have made to sort of grow their IGR year on year. For index index B rather, we try to see how with their total revenue. Now, mind you, when we reached out to a lot of states, to validate the data, and they are sending us back, their responses, they would often include loans as part of their total revenue just to boost the profile. But for the purpose of our methodology, we do not consider loans as part of total revenue. So for a number of states, you might see that we reported less for them in terms of total revenues because we do not consider loans as part of total revenues. What we consider as total revenue is your IGR, your FAC, which is your statutory allocation, and for your VAT, and for states that receive the solid minerals revenue or the 13% derivation, as the case may be, and your aids and grants, that's what we consider as that. For C, of course, debt sustainability index, that's also a mini composite index. And then for the last index, which has a weight of 10%, we try to look at states that are prioritizing capital expenditure over recurrent expenditure. So these are just a few highlights from the report. We try to do a summary analysis just to give you a view of how the states cumulatively had performed in the last 1 year. On revenue, cumulatively, the states were able to grow their revenue by 28.95%. That's if you put all the revenues of the 36 states together, it was at 6.6 trillion. For IGR, also grew very minimally to 1.8%. But when you look at IGR as a percentage of GDP, it tells you that we have not been able to properly tax our economy. And as we move along during the presentation, you see reasons why our states, even with large economies or relatively large economies, they are not, getting enough revenues internally from the economic activities happening within their domain. Marginally, it increased from 0.98% last year to only about 1% this year. So what this tells you is that for a lot of the states, their budgets, their expenditure is funded largely by federal transfers. What do we mean by federal transfers? The statutory allocation, the 13% derivation that goes to all producing states. And so for fact dependence, the fact dependence for states also grew to 61.45% in 2022, which sort of denotes the dwindling domestic resource mobilization capability of states. To further buttress the point around fact dependency, for 16 states depended on at least, on fact for at least 70% of their total revenues. Then 32 states depended on federal transfers for at least 50% of their total revenues. So this chart sort of shows you the relationship between the federal transfers and fiscal balance. You can see Lagos down here. The fiscal balance was in the negative deficit of almost 300 billion. But then, because of the large IGR, you see that for fact dependence, it's around, 27-28%. But the bulk of the states are hovering in the middle here, between 60 and 90%. So you see that for a lot of the states, they depend a lot on federal transfers for their expenditure. So for years where there are economic shocks and maybe there's a dip, whether in oil price or in oil production, you would realize that the receipts that would often accrue to states would reduce, and that would significantly impact how they spend on whether it's healthcare, education, infrastructure, or whatever it is they choose to prioritize. You see Bielsa there as an outlier. Almost 100%, about 93 or so percent of their revenue were transferred from the federal government, of course, primarily through the 13% derivation. So on expenditure as well, 8.2 trillion, it grew from 6.5 trillion, 5.8 trillion the previous year. On overhead costs, and we need to watch this, about 13 states increased their overhead costs from the previous year by more than 40%. So that whole conversation around the cost of governance is something we need to really take seriously, because we cannot be complaining, about the paucity of funds to properly fund the budget and continue to increase, our overhead costs in this manner. With Cross River having the highest growth in overhead costs. Next, there was also a year-on-year growth in operating expenses by 19.26% and in capital expenditure by 28.54%. But it's important to state at this point that when looking at these figures holistically, it's important to now delve deep into what was prioritized in terms of capex in that particular year. And you would find out that, I say this all the time, whenever government prioritizes anything, it always looks for the money to execute that thing. If you are not seeing government spend on anything, it's because it doesn't place priority on it. If it has to borrow to spend, it would borrow to spend. So whenever I hear the reason for why human capital development is not prioritized as the paucity of funds, 2019-2020 that spent about 20 billion naira on building an airport. And in that same year, the budget for the primary healthcare development board, of course, which was supposed to serve the primary healthcare centers in the state, was about 480 million. And the budget performance that year was 10%, which was about 48 million. In the same year that the government was able to find in excess of what was approved by the House of Assembly to fund the airport. So if you look at foreign debt as well, and this is one area that states that really have a heavy dollar-denominated debt profile should begin to look at. So 5 states, as at December 31st, 2022, had a dollar-denominated debt profile in excess of 250 million. Now, these states are highly susceptible to exchange rate volatility. And we took Lagos State as a case study. For Lagos State, with a debt profile of $1.25 billion, without acquiring an additional, dollar loan, their debt profile in naira terms increased from 560 billion naira to 933.92 billion naira, just by the mere fact that the naira was devalued from 448 to 747 naira to a dollar. So for states with that profile, they really need to check the appetite for, especially in these times, for acquiring dollar-denominated debts. Now, we come to some good news at least. I had said in the beginning of the presentation that it's not all gloomy, right? We've made some progress, but we still have a lot to do. With regards to education spending, and I'll use Ondo as a case study here. Last year, the representative of Ondo, the Ondo State governor who was here, he left here ashamed. What was the reason? Ondo's health spending per capita and education spending per capita was less than 400 naira. And because of that, a lot of conversations happened behind the scenes, which why that had gone unabated for a while. And this year, it will shock you to know that for health spending per capita, it increased to over 2,000, for health to over 5,000. So you begin to see the importance of these sort of reports in influencing reforms in the states. For education spending, we saw that for total spending on education as a percentage of the total spending for 9 states exceeded the UNESCO recommendation of 20%. And it's at this point also that I want to give credit to both the World Bank and the NGF for coming up with the National Chart of Accounts that allows you now aggregately look at what the states are spending on, whether it's health or education, for you to be able to do this kind of analysis. We were not able to do that before all of those states were able to align with the National Chart of Accounts. And 17 other states, and this is going by their budget implementation reports. If you look at their tables on the total expenditure by function, which tells you exactly the sector that the states have invested in the year, you would see that for 17 states, they actually exceeded 15% in terms of the total spending, not budget, the actual spending on education as a percentage of the total expenditure in that year. For health, just 2 states, Sokoto and Jigawa, were able to meet the Abuja Declaration. On capex per capita, again, 24 states spent below the national average of 4,499 naira, while 12 states spent above the national average of 2,200 per capita on education. And Ondo State was one of those states. And Abia can look at this also and improve, on the allocation of the budget, improve the allocation of the budget to healthcare. Because they were the only 2 states, last year that spent less than 1,000 naira per capita on healthcare. Then for under 5 mortality, the keynote speaker had dwelt a lot on some of these things. But just to drive the point home, for the national rate, 1 in every 10 children, do not make it to their 5th birthday. That's the Nigerian reality. If you now move to the northwest, it's even worse. It's 1 in every 7 child born in the northwest do not live to their 5th birthday. If you look at vaccination coverage, which sort of denotes how states are, immunizing kids against vaccine-preventable diseases, it's at 63.7% nationally. But for some regions, the rate is less. Now, one very interesting thing about all of these indices is if you look at the disaggregated analysis of this using the UNICEF multi-cluster indicator survey, you would see that there is a very strong correlation between education and health outcomes, right? So for whether states or regions that had, a higher education rate, you would see that in terms of the health outcomes, they were performing relatively better. And which also points to the state that you need to invest heavily in these two sectors if you are going to begin to see improvements, in your state economies. I know that when states talk about domestic resource mobilization, it's primarily around tax. And the truth is, you cannot tax a sick population. If the bulk of your population is sick, you invariably cannot get taxes from that population. And so it's important that, we invest heavily in education, in healthcare, to ensure that there are better outcomes in terms of healthcare, and these persons can seek jobs, gain employment, and pay, taxes back to the state. For health insurance coverage, the data says that 77% of health expenditure is out of pocket. And you can see why with our health insurance coverage. Just 2.8% for women, 2.7% for men. So it means the bulk of what poor people spend from their incomes is on healthcare. So quickly, I would run through this to fertility rates at 4.6 births. For antenatal care visits, this is also very, very important. Just 23% out of the survey population nationally, was recorded to have visited or sourced antenatal care at least 8 times before their delivery. Now coming to the state of state performance. On Index A, which looks at the ability of states to meet their operating expenses with just their IGR, you see that just 2 states, Lagos and Rivers, raised enough revenue to meet their operating expenses and had some left for capital expenditure. But you see a state like Kaduna, Ogun, and Anambra, the bottom 5. Let's go to the bottom 5. For Bayelsa, Zamfara, Katsina, Taraba, they needed at least 7 times their IGR to be able to fund their operating expenses, which also denotes the heavy reliance on federal transfers to be able to fund that aspect of their expenditure. So for Index A1 that looks at the IGR growth, Ogun State had the highest growth at 53% this year, and the worst decline happened with Jigawa. Their IGR dropped by 53% this year. Now the reason for this drop, because Jigawa had the highest growth last year at over 300%. But when we went back to check the records, we had seen that some of the components they had, captured as part of their IGR, theoretically should not be. So reimbursement, from the federal government or certain commitment made, to the basic healthcare provision fund as part of their counterpart funding was recorded as part of their IGR. So when we took out that component this year, that led to this really drastic drop. But that's not to say that on several aspects of their fiscals, they have not done very well this year. So on Index B, which looks at the ability of states to meet their operating expenses and loan repayments with their total revenue, you see that for a Plateau state, Plateau needed to borrow to be able to fund its operating expenses and loan repayment, not to now talk of the capital expenditure. For all the states that have more than one, all those states, Abia, Imo, Yobe, Zamfara, Plateau, had to borrow to fund some aspects of their operating expenses and loan repayment and their capex. For states that did well in this regard, Rivers, Ebonyi, Anambra, Bayelsa, Kaduna topped the chart. Index C, this is a composite index of 4 sub-indexes. We look at the debt to GDP ratio, debt service to revenue ratio, personnel cost to revenue ratio, and one other index. And on this, Jigawa came out tops. Bottoms, you had Cross River, Plateau, Adamawa. Then for Index D, to look at the states that are prioritizing capital expenditure over recurrent expenditure. Year in, year out, it looks like Rivers always comes out on top in this particular index. So you have Rivers, Ebonyi, Kaduna, Lagos, Anambra. These are states that, in recent times have continued to prioritize capex, over their recurrent expenditure. For the bottom 5, you see states like Plateau, Benue again, that have as high as 6 times their capital expenditure being allocated to their operating expenses, which doesn't augur well for the state. So if we come to the overall fiscal performance ranking, this year again, Rivers came out tops. There was a new entrant into the top 5, which was Anambra. For the bottom 5, you had Yobe, Plateau, Benue, Bayelsa, Zamfara. So on our recommendations, it's important for state governments to be able to fund health, whether healthcare or expenditure or infrastructure, that they are able to raise requisite taxes to do this. And to do this, it means they would need to broaden and diversify their tax base. If you look at the components of their tax revenue as it is, payee still forms a very large chunk of their tax revenue. States are not doing well with whether it's road taxes or direct assessments, which basically taxes entrepreneurs. And with road taxes, you can see from a lot of the structures in the states with regards to non-state actors collecting road taxes, why a lot of states, are not able to ramp up road taxes as the case may be. For the second recommendation, of course, there is a need for the states to prioritize capex. In a lot of those states, the road network is poor. I mean, I saw a video the other day. Somebody was trying to transport produce from the north to Lagos. 2 or 3 trailers containing damaged products. And you begin to wonder what, the effect would be on the business person and even the state with regards to, food prices and all of that. So states need to invest in road infrastructure, transport infrastructure, digital infrastructure, and actually resolve this issue around multiplicity of taxes. I know that the NGF, with the SABER program and the World Bank and PEBEC, they have interventions in this regard, but we really need to, speed up. Also, I saw a video, somebody paid, there were 75 stickers that somebody had to acquire, transporting produce from somewhere in the north to somewhere down here in the south. And so that cannot happen. All of this, at the end of the day, would lead the business person, to transfer the cost to the end user or the final customer, as the case may be. Of course, we need to improve budget credibility. States now need to, really pay attention on consistently and accurately projecting their revenues and expenditure. And why this is important is because if a state, puts up unrealistic projections for revenue, and then at the end of the day is not able to make those revenues to fund its expenditure, what usually suffers on the budget are allocations to critical social sectors. If it had planned to build an airport or build a road, and that was its priority, it would still do that. But then, because of the paucity of funds or revenue, or shortfall in revenue, you would see that it's the critical social sectors, health, education wash, that ends up suffering. So it's important that government, improve their budget credibility. Consequence management, this is very, very important. The states are in dire straits, as it is. They do not have that luxury of having people fleece the resources of the states, steal from the states, and go scot-free. So it's important that to be able to mobilize revenue also and utilize them effectively, that those revenues remain when they come in. And so the states need to institute very robust consequence management regimes to deter corruption. I would leave the recommendations on healthcare because, the panel will address that. Just to finally look at some of the limitations we faced when we were coming up with this study. So for the states, because a component of the operating expenses is interest on loans, so for a number of the states, we were not able to see a disaggregated data on their debt service for us to be able to ascertain what was their actual interest on loans. And that impacted also their operating expenses. Then also, this having states that have not, transited to their accrual basis, has left us to still deal with the cash flow statements of the states. I know that some states had, raised issues with this, but for uniformity's sake, up until we are able to have all the states transit to the accrual basis accounting, we would continue to rely on the cash flow statements to be able to put all of this together. Then, of course, for debt data as well, some of the states had gotten back to us to say that they had reconciled some of their debt data and what we had published, which, by the way, we got from the DMO platform, had changed. And so we also acknowledge that. Then the fifth and the last is that we did not get some feedback from the states, meaning that they did not have an opportunity to also make inputs with regards to what we had put up for them. So I would like to leave it here for now. Thank you.
Thank you very much, Bong Usen. Extensive, if you'd wait behind, please. Ini, if you could just wait behind. Very extensive presentation on the state of states. very soon, very, very quickly, the report would be launched for us to really take a look at how much work has gone into this. Would like to recognize the presence of a very active partner. He mentioned the NGF. The DG of the NGF is here, Dr. Kauru, with Zubaida Abiola as well. Let's give them a round of applause wherever they are. Thank you very much. So very, very quickly, would have, I'm afraid, just 2 questions. We have a very, very brief presentation on the accountability side of this discussion that our very own Dr. Deviana Biobele would be taking, and then would go straight to the launch so that His Excellency, the Governor of Kwara State, would be able to leave as soon as that is done. So Nancy is passing the mic around for 2 questions, very, very quickly, for Iniobong Usen's presentation, and then Dr. Biobele would be coming up 10 minutes to speak very, very quickly on an accountability project at the state level that really ties this conversation together.
Yes, there's one person. All right. Good afternoon, everyone. Standing on all existing protocols, I have a particular question I want to ask. It's concerning inflation. How much is inflation factored into some of these reports so that we know that states are actually making real improvements after inflation has been factored in? Thank you.
Good afternoon all. My name is Hoabeve from Nigerian and Malaria Council. So the former presenter from World Bank talked about exploring an area where more funds will be given to the state. So when you were doing a presentation, you talked about when the state governors have a priority, they can actually get the funds. So my question is, after engaging with the state for a long time, what do you think is the reason why most states don't prioritize health, knowing fully well that is actually the way forward? Because you gave an example that a state governor building an airport when they couldn't meet up with the funding for health. I can give you an example of someone that built 3 flyovers and said that was the priority, and he actually got the money. So using that same example you give, what are the reasons that we can get some of these subnational leaders to actually get this money to health rather than building airports? I'm not talking about that airport builder, I'm just using that as an example for the most of the state. Thank you.
Okay, yeah, thank you. With the first question, we use the nominal figures. We have not discounted for inflation. So I hope that answers your question. But I believe moving forward, that's one area we also would like to do, to see, in terms of the real figures, how, inflation affects, all of these figures put out by the states. But it's something we hope to do. With respect to your question, state governors they are politicians. They only invest in things that would get them re-elected. So the question you should ask is, the citizens, do they prioritize healthcare, right? If they are given a charter of, or if they are asked to produce a charter of demand, on the top 10, how many of those things on the list, right, would fall under healthcare or education? Because at the end of the day, right, the governor would only fund. Sometimes these things align, those interests align with the interests of the general public. But most times, they put their money in projects, in investments that will get them re-elected. And that's the game of politics.
That's putting me on the hot spot. It's all about we, the people. Education, healthcare, they're not one of those low-hanging fruits. If you invest in education, it'll take 15, 20 years before you see the results. Your next election is in 3-4 years. If you invest in healthcare, you don't even see any results. People don't appreciate it. Once patients walk out of a facility, they've forgotten about the investments done. And so it's about we the people. When a governor builds a flyover and asphalt roads, and they say, oh, the governor has worked very well indeed. He's done very well. Those are vote buyers, so they count amongst the people. So it's about indoctrinating ourselves, making sure that we prioritize education, we prioritize healthcare, and invest in education and healthcare. In Kwara State, we're doing that already. We're digitalizing our classrooms. We're making sure every classroom has a digital device. And that's important because it scales up what we're doing. To talk about that a bit, what we did as when we came in 2019, we saw that Kwara used to be number one in education in the north. Now we're at the bottom. Since 2013, we came in 2019, 2013, UBEC had blacklisted the state, so we had no access to UBEC funding. WAEC, that was the first letter I've indeed gotten from WAEC. They sent us a letter saying we had to pay 30 million because some of our schools cheated. Now, what did we do to begin to turn things around? Well, we did peer review. So that is something at the NGF level, it's encouraged. Look at what other states are doing. So we did peer review on education. We now saw Kaduna, Lagos, and Edo were doing very well indeed. What did Kaduna do? Kaduna sacked 22,000 teachers after aptitude test and employed 30,000 qualified teachers. And they started doing very well. What did Edo and Lagos do? They employed a company called New Globe. And what New Globe does is put a tablet in each classroom, giving every teacher a device. And what does the device do? One, it loads the curriculum. So, at that level of education, the basics, a teacher can teach 5 or 6 subjects. But if he specializes in mathematics, he spends half of his time freestyling on mathematics. I'm not paying attention to other subjects. But when you load the curriculum onto a tablet, the teacher is guided on what to teach daily. It enumerates the number of students in the classroom, and it clocks in the teacher as well. Sometimes a teacher might not know that a student doesn't come to school on Thursdays, for example, because there's a car or cattle market the parents take him to. But at the back end, we would see the data and interrogate that. In some cases, parents take their children to farms because of lack of mechanization. They need more hands on the market. So with such data we get, it helps us decide where to deploy tractors to. So putting digital devices in our school is a must, which all states should cover this. And during the Naira change, the last Naira economic spike we had, one thing most states did not know, based on the device, we saw that half of our teachers stopped going to school from the back end. And we said, how do we mitigate that? We couldn't send them money. Even if we sent them additional money, cash transfer, they did not have the cash to go into school. So it was not only the farmers that the Naira change affected. See, the economic challenges we're having today, some of it emanated from the Naira change because farmers could not get the goods to the market. Some that got theirs to the market could not sell it. And today, there are shortages because those same farmers could not go back to farm because of those shortages. Now, in terms of education, what we saw, we are able to see with digital devices in the classrooms the trends. issues of healthcare challenges. You want to know why students are not in classrooms. If they're sick, what was wrong with them? You can monitor malnutrition. So basically, well, I'm digressing a bit. Now, the point is, we the people are not taking healthcare and education seriously. When politicians are campaigning, you need to ask, what have you done in education? What have you done in healthcare? That way, you will force politicians to invest more in those sectors. But when you praise politicians for fixing roads or building highways and flyovers, they will continue to build flyovers for you. Thank you very much.
Thank you very much, Mr. Governor. The very calmly delivered points actually masked a lot of insight. And there was a lot of high-level content that His Excellency just spoke about, political considerations, policy direction, and we sincerely thank you for your presence here, for your just rendered comments. It's our honor to have you launch the report. We would be more than delighted to have you stay for the panel session. Our panelists are gearing up for a very, very insightful conversation and would be delighted to have you stay around, Your Excellency. Thank you very much for your comments. And thank you, everyone, for sticking around and paying attention. Dr. Biobele Davidson is right around the corner. I will be having her come up to 10 minutes to speak very, very briefly on our strengthening community engagement and accountability for primary health care. So she would be coming to speak. I won't have any questions after her, so we can go straight to the launch of the report. Dr. Biobele Davidson is the Strengthening Health Lead at the BudgIT Foundation. Please, let's give her a round of applause.
Good afternoon, everyone. As previous speakers have said, Your Excellency, I will take permission to not stand, but rest on existing protocols. So everyone has spoken, and one thing we at BudgIT Foundation is gearing towards its ownership. The community owns the health system. The community should take accountability for the health system. The community should demand the change and contextualize the change they want. So that being said, I will be introducing the Strengthening Community Engagement and Accountability for Primary Health Care. So in 2021, BudgIT Foundation decided to expand and also to include accountability for health system into one of its units, and then the SHS system was formed. Next, please. Okay. Okay, so we're resting on 4 pillars, which include health financing and policy analysis. That's why we're here. We're also looking at strengthening primary healthcare systems and accountability, facilitating civic ownership, participation in service delivery, and stakeholders' engagement in primary healthcare system. For that, we have our executive secretaries and the Honorable Commissioner of Health, which are seated in this room. Now, strengthening community engagement and accountability for primary healthcare, which is the SKIP project, is committed to accountability for primary healthcare to improve primary healthcare delivery at the PHC level in Nigeria. What we've done with this project is to lead community advocacy, monitoring of service delivery, financing, technology, and infrastructure deployment. We were able to create a platform which is called the PAT portal. It stands for Primary Healthcare Accountability Tracker, where citizens can go, patients can go and give their feedback on how they received service, what service they went to receive, and then also ways in which we can improve the primary healthcare in that community. Now, it also seeks to improve access and utilization of healthcare services through community advocacy, strengthening government's commitment to fund and deliver quality healthcare. The SKIP project is empowering community actors towards transparency, improvement of healthcare facilities and services, ensuring equal participation and inclusive involvement, especially for persons who are grouped under the vulnerable population and members of target communities. Our outcome areas of the SKIP project. What we've been able to do is to strengthen data. We were able to collect data, use this data as evidence to drive institutional engagement on fiscal issues and accountability for primary health care. We're also able to strengthen citizens and community voice and participation in primary care advocacy and accountability through service delivery, financing, infrastructure, and PHC facilities in all the communities where we are actually implementing. We're also able to improve community tracking and feedback mechanism using the PHC portal, which I will actually show to us in a short while. And then also influence social behaviors and institutional accountability through incentivized programs for healthcare workers and PHC delivery. And recently, one of the speakers said there's something called the Japa syndrome. And one way His Excellency also put it is, how much appreciations do we give to our healthcare workers? Patients will come in and say, thank you, oh, doctor, you're good, and then the next day they don't remember you. The same patients, you go and then engage with them. For example, you go to the market and like, doctor, you have money. Those are things we've seen over the time. And we're not saying give us services at reduced prices, above or below your cost price, but also to ensure that we actually encourage workers who are currently in the system, and then also encourage those who have left the system to return back to the system. This is what our portal looks like. It's www.phctracker.org. It's live. You can go on it. You can see what we're doing. It's actually covering 5 states presently, namely Gombe, Kaduna, Kano, Niger, and Yobe. But the way the portal is structured and built, it can actually cover the 36 states, including the Federal Capital Territory. And most importantly, it is a portal that is open for expansion. Okay, so I'm a doctor. Technology is not really my best friend. So what we have done on the portal is profile facilities. We have 15 facilities. Gender inclusion is something that is key in budget. We were able to carry out a gender analysis survey because there's no way we can actually strengthen our primary health care without looking at the target population. Gender inclusion is not just limited to women and children, but now this survey has been able to solve some missing gaps. For example, we have people who say the distance to my facility is more than an hour, and that's not the recommendation. The walking distance to my facility, tailored to a particular age group, target-driven services to counter or to encourage service. We had meetings with the NPCH, we had meetings with CHDA, and then we also had meetings with other stakeholders. So we had written a letter to them, we also had engagements with them, we had a meeting, and they were part of the people who had helped us in restructuring our portal and questions on the portal, sir. At both the federal level and the state level. So we also had a state coordination meeting in the last month where we visited all the 5 implementing states, met with the executive secretaries, provided an update report, and also met with community members, WDCs, and focal persons in the state.
I don't know if any of our ESs or the Commissioner for Primary Health would like to respond very quickly to any of the issues that she has raised. Okay, so I'll take that as a no and then we can continue. Thank you so much, Dr. Biobele. Right now I'll call on our country director, Mr. Gabriel Kewo, to commence the launch of the report. Let's give him a round of applause, please.
Thank you very much, Viola. Thank you, everyone. We want to launch the reports now, and shortly after the launch of the reports, please, I need help. Can we wheel this to the middle? After the launch of the reports, we'll then go into the panel session for today. Please help. And it's my great honor to invite first the Executive Governor, Kwara State, and the Chairman of Nigerian Governors Forum, and then every other person that is on the high table here. Please join us on this side. And then I'm going to be inviting Katia from the Bill and Melinda Gates Foundation to please join us. I'm going to be inviting Zainab from the International Monetary Fund, IMF, to please join us. I'm going to be inviting, yes, DG NGF, Dr. Cairo, please can you join us here too? I need to infuse more female into this thing. it was never our intention to have all male seated in front. We are sorry. More female that I saw. Which other female do we have around here? Yes, media, female media journalists, please join us. Representative of Dr. Faiza Shuaib, Chairman of National Primary Healthcare Development Agency, please join us. It's fine, don't worry. Don't worry, it's fine, I'm okay here. Yes, okay, so, sir, you say a bit of word and then you unveil the reports. Thank you, sir.
Well, ladies and gentlemen, this is the much awaited report. So. Thank you.
Thank you very much, sir. I think we can all pick one each for media. Yeah. Too wide? Let's close. All right. Thank you, everyone. I believe right now, as we have launched this report, the soft copy is also available on our website. So if you want to download soft copy, please go to the website. If you want a copy, please stay back here to get a copy right here. And then it's fine. It's fine.
What did you say?
Yes, you can pick a copy, but we'll still we'll send it back to your own to the office. All right, we go straight into the panel session, please.
Thank you very much, sir. Congratulations to BudgIT for putting this report together. I know how many sleepless nights I had putting it together. Thank you to the Executive Governor of Kwara State for being our chief launcher, alongside the DG of the NGF for launching the report. Thank you so much, ladies and gentlemen. I would like to transit to the very next and very pivotal aspect of today's event, the panel session on subnational healthcare delivery for improved economic development, finance and beyond. Subnational healthcare delivery for improved economic development, finance and beyond. If we could have everyone settle down so we can get to this next session, we would be delighted to continue and to commence our panel session. Very, very quickly, I would like to call on our moderator for this event. If we could have everyone settle down, that would be great. Right, so we are here to discuss subnational healthcare delivery, and who better to do that than representatives of the various states that you may have heard being mentioned during the several submissions today. If we could please settle down so we could go to the next session. Thank you very much, everyone. If we could just quiet down a little bit. I know the networking is an important aspect, but we have very little time.
Ignorance and skies, be yourself, no matter what they say.
Okay, can we please settle down, everyone?
No matter what they say.
All right, so very quickly I'll call on Dr. Kemisola Agbawe. She's the moderator of today's panel. Dr. Agbawe oversees all program activities at Nigeria Health Watch and leads the design and implementation of the organization's policy advocacy and communications projects. If I could have everyone's attention, please. And these are across a wide range of focus areas, including sexual and reproductive health, maternal and child health, gender equality, health system strengthening, health security, and infectious diseases. She has ongoing research interests in the use of evidence to influence health policy and practice, and she regularly contributes to the Nigeria Health Watch editorial on this. Dr. Gbawi would be the moderator for this session, and she would be introducing the panelists. Please let's give her a round of applause as she mounts the podium to take over this last and final session. Thank you very much, Dr. Gbawi.
Good afternoon, everyone. Good afternoon, everyone. It's been a really insightful meeting so far. I would like to use this opportunity to say a big congratulations to BudgIT Foundation on the launch of the 2023 State of States report. So in this panel session, we're going to be looking at subnational healthcare delivery for economic development with a focus on more than just financing. And please do me the favor of putting your hands together as I welcome my esteemed panelists. Dr. Babagana K. Machina, who is the Executive Secretary of the Yobe State Primary Healthcare Board. Please put your hands together for him. Dr. Bello Jamo Yusuf, the Executive Secretary of the Kaduna State Primary Healthcare Board. Good afternoon, sir. Dr. Abdurrahman Shraibu, the Executive Secretary of the Gombe State Primary Healthcare Board. And Dr. Ibrahim D. Dangana, the Commissioner of the Ministry for Primary Healthcare in Niger State. First of its kind. And joining us online is Dr. Ahmad Abdulwahab, who is the Senior Health Advisor at the Nigeria Governors Forum. He is unable to be with us here physically.
Well, let's see. Okay.
Hi, everyone. Okay, so very quickly, this is, for me, I think one of the highlights of this event. This is where we get to hear from the subnational leads themselves on how they are improving primary healthcare delivery in their constituencies. And I'm particularly looking forward to the discussion because on this panel, I have one of the top 5 states based on the State of States reports. And we also have some states who, for example, have significantly increased spending on health, like Gombe State, for example. We have Niger State. Niger State has hit a huge milestone. There's now a Ministry of Primary Healthcare in Niger State. That, I think, is really impressive. And we'll be hearing a lot more about that. And we have someone from Yobe State. Yobe is smack dab in the middle of the Boko Haram insurgency, and yet is able to significantly contribute or significantly increase and improve the health of its citizens. So you'll be hearing from really important people here this afternoon. So first off, to start off, and this I think is a question that I would like to ask all of you generally, and it's, what exactly would you say? We've talked about the problems. We've looked at the data. We've seen what the health indices are, from child health to maternal health. What would you say are the key challenges that you are experiencing in your states in improving primary healthcare delivery? And any one of you can start. But since I see that you have the mic already, so please go ahead and start.
Thank you very much. For Gombe State is one of the 6 states in the northeastern region, and it shares borders with other 5 states. And because of its relative peace, it has seen a lot of migration from other states. And so, as the healthcare, the population increases, so is the healthcare needs of the population. One of the major challenges in Gombe State is in the areas of human resources for health. We have a huge gap across all cadres because there has been an embargo on recruitment for the past 6 years, since 2015. However, the state government has taken major steps to address that. Last year, the state government recruited 440 healthcare workers across all cadres. And this year, approval has been granted to recruit 200 more healthcare workers. At the Primary Healthcare Development Agency, we've signed an MOU with the State Ministry of Health, where we secured 150 midwives being posted to the State Primary Healthcare Agency, and we in turn posted them to primary healthcare facilities. This is because we noticed that nurses midwives were concentrated in urban and secondary healthcare facilities. The state government has also gone into partnership with a consultant to provide biometric attendance across primary healthcare facilities. Initially, we pilot tested with one local government, and we upscaled to 4 more local governments. Gombe State has 11 local governments. So we have 5 local governments that have biometric attendance. And what makes our biometric attendance different with other ones is our biometric attendance is being linked to our payroll system at the AG's office. So it has increased the availability of healthcare providers in our facilities, thereby decreasing absenteeism. And we've even gone further to see how we look at other indices, looking at health worker productivity. You come to work, but how many clients do you attend to? Apart from that, we are also looking at increasing the production of healthcare providers. The state government presently has a college of nursing that only produces 100 nurses midwives annually. The state government has started construction, or is at almost completion now, 70 or 80% completion, college of nursing that will produce at least 600 nurses midwives in the state. So we are looking at the challenges both on the short and also in the long term. Yeah.
Thank you so much. You've touched on one of the foremost challenges that we face in the health sector, particularly at the primary healthcare level, human resources for health. And I like that you've spoken to both production and retention, as well as increasing the productivity of your health workforce. I think that those are really key lessons that other states could take on. I will come back to you, but I wanted to see if any other... Yes, please, go ahead, sir.
Thank you so much, BudgIT. The situation in Kaduna State is very similar to what obtains in Gombe State. We perform regular bottleneck analysis in the state regularly, identifying the common and important challenges facing us towards delivering quality healthcare. And the number one that almost pops out is the challenges as attributable to human capital. I'm not going to say much regarding that. We have more than 1,000 primary healthcare centers in Kaduna. So even if one requires about 20 staff to manage, that would be about 20,000 requirement. And we fall short of that number. So it's a very, very important challenge. And there are some processes on the ground to alleviate that. But it's not just the number. The skill, the requisite skill is very, very important, and it's also challenging. We have this horrible statistics of less than 30% of all health deliveries being attended to by skilled, trained attendants. So this is a challenge, not just the quantity, but the quality. The day before yesterday on a Sunday, we visited a PHC in a remote village in Zaria, a local government in Kaduna. We were going through the books. We saw this case of delivery, a 22-year-old lady who presented then But they found out that all these were recorded in the book. They saw a BP, blood pressure of 160/110, and sublingual aspirin was given. Aspirin is not an antihypertensive, and it's not given sublingual, but it was actually given. But the record went ahead to document the actual delivery of the child and then discharge of the patient. So this is a bad experience. Aspirin thins out the blood, and coupled with the high blood pressure that she was presenting, there was an increased risk of hemorrhage, which is #1 cause of maternal mortality. So we had to go and trace that woman at home to measure the BP again and take necessary action. So the point here is not only the number of the health staff, that's a challenge, and also the requisite skills that are there. We don't see it. So this is a very, very important challenge that we have. Thank you.
Thank you so much. So you're looking at the quantity and quality of healthcare workers that you have and the sort of training that they have. So I see Dr. Dangana nodding vigorously. Do you want to go next, sir? Before I come to Dr. Mashina.
Well, I nodded my head because he actually hit the nail on the head. It's just not the numbers, but the knowledge and the skills of what you have on ground. For us in Niger, I would want to say so far since morning, we've had a lot of insight from His Excellency, the Governor of Niger, from the keynote speaker and the various people that have spoken. This panel discussion will just add maybe some specific as to the state. So for us in Niger, Niger is the biggest state in the country with 10% of the landmass of Nigeria, collectively bigger than the entire western state, Lagos apart. So we have more than 2,000 PHC centers. Where do you begin? How do you deploy staff? How do you monitor them? How do you fund this facility? So it's a huge challenge. And like my colleague Ngombe has said, we've had an embargo placed on employment for 8 years, which was just recently lifted. So there is a huge gap in meeting the needs of the healthcare system. And coupled with that, the motivating factors are not there. Everybody wants to work in the urban areas. When you look at the current distribution of our workforce, they are largely concentrated around the urban and peri-urban areas. So how do we get this manpower to go to the rural areas? The incentive programs are not there to encourage people to stay. In the period of that embargo, we've had to employ over 800 staff, deployed mostly to those rural areas. But keeping them there, it's a huge challenge because as soon as they get better offers, people tend to leave. So it's, I think it's one of the reasons why we need to look at new strategies to ensure that as we deploy this workforce, they will be willing to stay. One key thing is also to come up with programs that will allow them to go for further studies. You bond them and they return to the state. So let me just stay here. I believe there are more discussions as we continue. Thank you.
Thank you so much, Dr. Dangana. Dr. Mashina?
So much. As rightly said, Yobe State is one of the worst hit states by the insurgency in northeastern Nigeria. And the health sector is one of the worst hit also, even within the state, from the activities of the insurgents. For instance, I'll speak for the PSC system specifically now. 27 of our PSC centers were completely razed down. 27 completely razed down across 6 LGS in the state by the insurgents. And over 48 health workers have been killed, including 3 doctors. That actually scared away a lot of health workers from the state, especially those that are non-indigenous to Yobe. Although the state government has, within the last 4 years, built a new or rehabilitated and expanded 139 PSC centers across the state, including 11 of the 27 burnt down PSC facilities. 16 of those could not be immediately rebuilt because the security situation there is still fluid. And we don't want to build and then only for it to be burnt down again, because that happened with one of them. There's PSC Mandonari in Gojba LGA that was rebuilt and completely burnt down for the second time within 8 months. So because of that, the remaining 16 are yet to be rebuilt. But it is not only the issue of the buildings or the infrastructure there. The human resources, as I have said, have been affected, generally scaring away people. So we have seen mass exodus of health workers from Yobe State, even those that are from the state, but more so those that are from outside the state. And to mitigate that, the government took a very proactive measure of looking at developing our indigenous human resource base for health, increasing the capacity of the health training institutions in the state to be able to produce more and retain them, and developing a bond system where each of our 178 PSC or political wards in the state gets female secondary school leavers actually admitted into the midwifery, community midwifery program in the State College of Nursing and Midwifery, and trained for free with monthly incentives, which over the last 2 years have been doubled by the government to serve as motivation for them to actually stay there. But with a caveat that after graduation, they have to go back to those communities that they hail from and provide services, because we have seen that unless we engage people that are in those communities that have their parents or their relatives there, and have a lot of affiliation there, the motivation to stay in those areas, some of which are security compromised, may not be there. So with this approach, the two government-owned health training institutions in the state have seen more than triple enrollments, getting all the necessary accreditation from the regulatory bodies and the rest. So we are producing more, and then we are retaining them to be able to provide services there. The issue of the human resource has been one of our greatest challenges, because you can rebuild infrastructure within 3 months, 6 months, and the rest. And for us to do all of these things, there needed to be, increased spending on health. And within the last 3 years also, the resources allocated to the health sector has more than doubled, as rightly captured even in the report of the State of States here. So this year alone, in the PSC alone, we have had increment of our budgetary allocation by nearly 3 billion naira to the PSC alone, to help rebuild the remaining 45 ward local PSCs, and then engage additional human resource for health in the coming year. So these are key challenges that we are working hard to overcome.
Thank you so much for sharing those. And you've already touched on financing. I mean, one of the most prominent parts of the State of States report is financing, and how a lot of states don't have enough internally generated revenue and there aren't enough allocations to health. So are there some bottlenecks that you have identified in your states that limits the ability of those funds to reach the point of service delivery? So whether it's from allocations by your state government or in your relationships with your health management agencies, for example. And are there some that you just want to very quickly share before we move on from bottlenecks? Anyone can go.
Insight from nature. Just like said earlier during the day, it's not about the budgeting process per se, but the releases that gets to the primary healthcare board or the Ministry of Health. So we've had a time even before the pandemic era. Pandemic era made matters worse. It underscores the need for government to put in more resources in the sector. But for us, we felt the state was not doing enough to put in the necessary resources, because usually when you go to the budget defense, you have a cap. At the agency, we have a cap. Your cap may be 200 million naira for the entire budget session for the year. That 200 million naira, ladies and gentlemen, will not even fund the immunization program for the year, let alone service delivery across 2,000 facilities, let alone capacity and training building, training, learning, evaluation, and even infrastructural maintenance. So then we had the era with the COVID, the depreciating revenues. The state tells you to leverage on the partners. So like rightly said by the keynote speaker, the basic healthcare provision fund for many states was the only game in town. When you go to secure releases, they tell you, doctor, please leverage on your partners. So we've had that bottleneck. Yes, you get the approval of His Excellency for budgetary release, but getting the actual cash backing becomes a very huge challenge. And for us in the health sector, the presence of partner has been both a blessing and a curse. A blessing in the sense that partners have stepped in to cover the gaps, but we have to remember partners are there with specific interventions across programs or areas of interest. The state needs to do its part. And the cost in the sense that their presence has not allowed us also to assess funds on the part of the government. Government will rather say, since you have a lot of partners in health, we need to reprioritize the few available resources to other critical sectors. So it's a huge challenge. We've had a number of MOUs with important organizations like the Bill and Melinda Gates Foundation. We have with the Global Alliance for Vaccine Initiative through UNICEF. We have with GIZ and others. But actually getting government to even put in its own counterpart has been a huge challenge. But hopefully for us, with the creation of the ministry and the reinvigorated interest from His Excellency, the Governor of the state, we are already seeing an injection of more funding into primary health care. Thank you.
Sorry, Dr. Dangana, before we move on from you, could you share what informed the creation of the new ministry? Why did that change have to happen, and what does it mean going forward for primary health care delivery?
Okay, so let me put it this way. We've had a transition committee in place before the new governor came into power. Our notes were there. But one critical thing, His Excellency, the chair of the Nigerian Governors Forum, has shared an insight why politicians are not really deploying resources into health. They are not low-hanging fruits. But on a good note, my governor said, I went around the states during my campaign. I went around the 24 local government areas. I went around the 274 wards in the states. I have had time when occasionally I have to take a little break in the PAC facilities. And he said, then I was the ED for the primary health care board. He said, ED, what most of your facilities have are just benches and curtains. I don't see equipment in, and I don't see, I go to some facilities and I looked around, there is only 1 or 2 staff. So he realized there is a big problem in primary health care. And so with the transition briefing, he realized even most of the resources coming in from the federal level to the state are actually not getting to all the PAC facilities. They are only being concentrated at the focal facilities. And the focal facility, a state with a population of about 7 million people, how much targeted populations do they serve? So what happens to the remaining, if we have 274 focal facilities in the state, what happens to the remaining 1,700 plus facilities? It means we have left them to their fate. So that was one of his things. He felt PAC was so large, it is the bedrock of the healthcare system, and he feels it is just too big for one ministry to manage alone. He said, let's look at education. We have Ministry of Basic Education, then we have Ministry of Secondary and Tertiary Education. So why not go a paradigm shift in health to see if things could change? And at the briefing, again, one of the constraints that came up prominently is that the state's primary care board, as they are constituted, have their limitations. They are not fully autonomous. So they are basically competing for resources with the Ministry of Health. All right? Your capital expenditures are under the ministries. Your memos are routed through the ministries. If there are competing needs on the part of the ministries of health, then you may not get a fair, representation at the council. So he felt with the creation of the ministry now, we should be able to surmount some of these limitations. And hopefully with the creation of the ministry, what we're adding here is we will see a more catalytic release of funds to the health sector. It's a win-win situation. The old Ministry of Health, now termed secondary and tertiary healthcare, will concentrate on its own mandate to manage the general hospitals as well as the tertiary hospital in the state. And the new Ministry of Primary Healthcare, with the resources being devoted to it now right from the budgeting process, is tasked within a phased period to remarkably improve and strengthen the PAC system in the state. So we are bringing in new workforce. We're seeing new release of funds. For the first time in the last 2 years, we have seen releases of funds to back up some important counterpart or MOU commitment. So these are some of the reasons that inform that. And of course, one other key thing was the fragmentation. What we've tried to achieve with the primary healthcare under one roof. When the board, as it was, we do not have the powers to recruit our own staff. It has to go to the Ministry of Local Government Affairs. We do not have the powers, like I said, to present memo to His Excellency the Governor. We do not have representation at the council. So there are a lot of fragmentation. Now he feels, okay, let's have a ministry with equal powers to these other ministries that over time have subsumed the functions of the State Primary Care Development Board. So hopefully it's a new shift, it's a new paradigm shift, and already we are off to a good start with the roadmaps we've developed, with the waiver we've got now to recruit 1,500 new staff, with the budgetary process which was just completed last week, as well as with the fact now that we'll be able to manage our own staff, plan capital expenditures, and execute the mandate of PSC better in the state. Thank you.
Thank you for sharing that experience, especially because now you can manage your own staff. I think that's one consistent challenge that I hear from executive secretaries of state primary healthcare boards. Dr. Shuaibu, did you want to share?
Yes, okay, thank you very much. For Gombe State, looking at where we come from, initially budgetary allocation for the PHC was about 3.5%, but we have seen gradual improvement over the years, and now we have reached 12%. But it is not the budget allocation that is most important, it is the budgetary release to the sector. In the state, we have almost fully implemented primary healthcare under one roof, and then we have a budget line. But however, when this administration came in, it did a needs assessment, and one of the topmost requirements that came out from the household survey was that there was a need to provide healthcare delivery at the grassroots level. So the state governor took it upon himself to revitalize 114 primary healthcare facilities. We have 114 wards, so one facility per ward. And with that, after that, the Contributory Health Management Agency was established. And we have seen with the commencement of the formal sector, we have seen a lot of confidence has been built among our people. They tend to select public primary healthcare facilities as their primary providers compared to private facilities, despite having options to choose private facilities. And the big learning for us is that when there is investment is made in primary healthcare facilities and provided with basic equipment and the manpower, I think there will be more people will utilize a primary healthcare facility. So public trust is an important factor. And I have mentioned earlier that the state government had a contract with a consultant, for biometric consultant, and throughout the period of the engagement, the state government has been able to save about 400 to 450 million naira in 7 to 8 months, and that has been able to free resources. We are able to conduct promotions, recruit more staff, and also paid counterpart fund. And also the facilities were provided with more funds because more vulnerables were recruited. For the vulnerables, we have 3 gateways. BHBF, the state government has been consistent in paying its 25% counterpart fund. And the state government also enacted a law that earmarked 1% of its consolidated revenue for both the state and local government to pay for the poor and vulnerable. And that has also provided more funds for the facilities. And we have even gone further to do advocacy to donor agencies. For example, UNICEF just recently paid premiums for 10,000 vulnerables. And that has also provided more resources for the facilities. So we have seen a situation whereby facilities are advocates of the Contributory Health Management Agency, sensitizing communities about the importance of paying premiums because they know that it provides resources for the facilities to run their operational cost. Thank you.
Thank you so much for sharing those. Now I see why Gombe is fourth for health spending based on the State of States report. Thank you for sharing those. Dr. Yusuf or Dr. Mashina, do you want to add quickly to that? And then we'll go to Dr. Abdul Wahab online.
Okay, the story is actually very similar. We've heard from the lectures in the release of government's counterpart to the PHC MOU funding. We have funders from Bill and Melinda Gates Foundation, Aliko Dangote Foundation, UNICEF. But perhaps it's the election year. We couldn't get it on time for 2023. I think just about 2 months ago, we got the government's counterpart funding. So it's just the delay in this aspect. I'll quickly say here to the development partners, we also have some sources of funding that are actually decent. But the only problem is about prioritizing. Somebody giving you a donation, they come with their mindset, with their priorities. But sometimes it may not actually align with your own priorities as the recipient. For example, they will say they will not fund infrastructure, they will not fund manpower, but they actually they could be priorities in actual sense. So these differences in the priorities between ours and what the donors come up with is something worth mentioning. I don't know whether I'm empowered to say this here, but this is actually what we see sometimes.
I mean, you're touching on something that I think everyone in the health sector understands, that a lot of our health programs are donor-driven. They're driven by donor interests, and they're driven by, sometimes the agenda is set before it even gets here, before conversations are had. So I don't know either if you're empowered to say it, but thank you for touching on that. I think that is an important challenge to bring forward. But before you drop your mic, sir, a study by BudgIT, an empirical study, showed that there was some shortage in the availability of nurses and midwives in your states. But I think that's a shortage that's everyone knows is across the whole Nigeria. What would you say, or what is Kaduna State doing to meet those shortages in specific terms? If you could answer in 2 minutes or less, that would be great.
It's an important problem. Actually, we have realized the issue of brain drain is playing a great role. Not only the Japa syndrome we're seeing, but even internal brain drain. We see it. Internal means from Kaduna, for example, we may see some healthcare workers migrating to Yobe State because of perhaps a better pay and working condition. So that we have realized, and the one thing that we are doing is first signing an MOU with the National Youth Service Corps to say that all the doctors posted to the state are being deployed to the state. And they are actually retained in the public facilities rather than going to private. And the posting also, we have some incentives. We incentivize the postings. There are rural posting allowances, mindful of the security challenges in some places actually. But we want to actually have a means of retaining them by incentivizing that. My brother from Yobe also spoke about consulting the schools of nursing and midwifery. We also have done that in a bond kind of situation that after graduate we sponsor the indigents, and after graduation they get posted to particular posts to stay for at least 2 years to work before getting them to mind their business elsewhere if they so wish. Not only I talked about the manpower gap. The state government, we have just gotten the approval to recruit 1,000 staff annually, and a standing order to replace those that have disengaged either because of death or retirement or some other reasons. So this one, we've been empowered as PHC to do the replacement, and then 1,000 number of health staff to be recruited annually. And of course, the mentorship program we felt is going to enhance the workplace